Senator Kunish.
Mr. President, I oppose the call of the Senate.
The Senate has been under call. Senator Kunish.
Then, Mr. President, I move that further proceedings under the roll call be dispensed and that the Sergeant at Arms be instructed to bring in the absent members.
On that motion, any discussion? Seeing none, all in favor say aye. All opposed say no. The motion prevails. Members, if you be so kind as to stand. Today's chaplain is Pastor Kyle Jackson from Calvary Lutheran Church in Excelsior, Minnesota. And following the prayer, members, please remain standing for the Pledge of Allegiance.
Let us pray. Spirit of the living God, fall afresh on this place. Your spirit which hovered over the dark of deep chaos, hover over us now and bring order and light and wisdom and peace. Embolden, empower, and engage this body to do your good work today. Give this body courage where there is fear, action where there is apathy, and to always put love over hate. As this body often sits in primary colors, show us your affinity for building bridges instead of walls. Give this body the ability to step across aisles that seem insurmountable, and show us that your most glorious sunrises and sunsets are indeed purple. We give great thanks for these servants, God, and ask that you would bring each of them and the Minnesotans that they represent a measure of your peace that passes understanding. Amen.
Amen. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thanks, members. The Secretary will take the roll.
Abler, Anderson, Barr, Bolden, Carlson, Champion, Coleman, Swadzinski, Dames, Dibble, Dornick, Draheim, Drazkowski, Duckworth, Diedzik, Eichhorn, Farnsworth, Fateh, Frentz, Green, Grunhagen, Gustafson, Hoschild, Herr, Hoffman, Housley, Howe, Jasinski, Johnson, Klein, Coran, Kroon, Kunish, Kupek, Lang, Latz, Liskey, Limmer, Lucero, Mann, Marty, Matthews, Mayquaid, McEwen, Miller, Mitchell, Mohammed, Morrison, Murphy, Nelson, Umu Verbaten, Pappas, Pa, Port, Pratt, Putnam, Rarick, Rasmussen, Rest, Seeberger, Utke, Weber, Wiesenberg, Westland, Westrom, Wiklund, Zhang.
Members, pursuant to Rule 14.1, the following members intend to vote under Rule 40.7. Senator Diedzik, Senator Gustafson, and Senator Lang. Members, a quorum is present. As usual, members, if you want to follow along, I have the Senate agenda dated Wednesday, April 19, 2023, and we will begin with the third order of business. Messages from the House. The Secretary will read the message.
Mr. President, I have the honor to announce that the House has appointed a committee of 5 members of the House to act with a similar committee on the part of the Senate to escort the governor to the joint convention to be held in the House chamber on Wednesday, April 19, 2023, said joint convention to be convened at 6:45 p.m., and said message of the governor to be delivered at 7:00 p.m. Clardy, Finke, Purcell, Torkelson, and Erdahl have been appointed as such committee on the part of the House. Signed, Patrick D. Murphy, Chief Clerk, House of Representatives.
Members, no action is required. The Secretary will read the next message.
Mr. President, I have the honor to announce that the House refuses to concur in the Senate amendments to House File Number 2073. House File Number 2073, a bill for an act relating to higher education, providing funding and policy-related changes for the Office of Higher Education, Minnesota State Colleges and Universities, the University of Minnesota, and the Mayo Clinic. The House respectfully requests that a conference committee of 3 members be appointed thereon. Pulowski, Wolgamott, and O'Neill have been appointed as such committee on the part of the House. House File Number 2073 is herewith transmitted to the Senate with a request that the Senate appoint a like committee. Signed, Patrick D. Murphy, Chief Clerk, House of Representatives.
Members, I'm calling on Senator Fateh for a motion. Senator Fateh.
Thank you, Mr. President. I move that the Senate accede to the request of the House for a conference committee on HF 2073, and that a conference committee of 3 members be appointed by the subcommittee on conference committees on the part of the Senate to act with a like conference committee appointed by the part of the House.
Senator Fateh moved that the Senate accede to the request of the House for a conference committee on House File Number 2073, and that a conference committee of 3 members be appointed by the subcommittee on conference committees on the part of the Senate to act with like conference committee appointment on that part. Any questions or any discussion? All in favor, seeing none, all in favor say aye. All those opposed say no. The motion prevails. The Secretary will read the next message.
Mr. President, I have the honor to announce that the House refuses to concur in the Senate amendments to House File Number 1999. House File Number 1999, a bill for an act relating to state government, appropriating money from outdoor heritage, clean water, parks and trails, and arts and cultural heritage funds. The House respectfully requests that a conference committee of 5 members be appointed thereon. Lilly, Hussain, Herr, Cha, and Backer have been appointed as such committee on the part of the House. House File Number 1999 is herewith transmitted to the Senate with a request that the Senate appoint a like committee. Signed, Patrick D. Murphy, Chief Clerk, House of Representatives.
Senator Herr on a motion.
Mr. President, I move that the Senate acceded at the request of the House for a conference committee on House File 1999, and that a conference of committee of 5 members be appointed by the subcommittee on the conference committee on the part of the Senate to act with the like conference committee appointed on the part of the House, Mr. President.
Thank you. Senator Herr moves that Senate accede to the request of the House for a conference committee on House File Number 1999, and that a conference committee of 5 members be appointed by the subcommittee on conference committees on the part of the Senate to act with a like conference committee appointed on the part of the House. Any discussion? Seeing none, on that motion, all in favor say aye. All those opposed say no. The motion prevails. Members, the Secretary will read the next message.
Mr. President, I have the honor to announce the passage by the House of the following House file herewith transmitted. House File Number 1826.
Members,
Signed,
no motion.
Patrick D. Murphy, Chief Clerk, House of Representatives.
Sorry about that, Mr. Secretary. No action is required. Members, we will now proceed to the 4th order of business, which is the first reading of House bills. The House files have been given their first reading and referred as indicated. Members, we will now proceed to the 5th order of business, reports of committees. Senator Kunis for a motion to adopt the committee reports.
Mr. President, I move the committee report printed in the agenda be adopted, and I believe that is being handed out.
On the adoption of the committee reports, all in favor say aye. Those opposed say no. The motion prevails. Members, we will now proceed to the 7th order of business, which is the second reading of House bills. The Secretary will read the House file numbers.
House File Numbers 1937 and 1830.
The House files have been given their second reading. Members, we will now proceed to the 8th order of business, which is introduction and first reading of Senate bills. The bills listed on today's introduction calendar are given their first reading and referred as indicated. Members, we will now proceed to the 9th order of business, motions and resolutions. We will adopt the author's motions as one motion. All in favor say aye. All those opposed say no. The motion prevails. The Secretary will report the resolution.
Senators Dietzick and Kunish introduced Senate Resolution Number 44, a Senate resolution relating to appointment of a committee to escort the governor to the House chamber for a joint convention.
Senator Kunis for a motion to adopt and explain the resolution. Senator Kunis.
Thank you, Mr. President. The resolution is simply to assign those who will escort those this evening at the State of the State address.
Senator Kunis, you need to move to adopt.
Mr. President, I move to adopt Senate Resolution 44.
All those in favor say aye. All those opposed say no. The motion prevails. Members, pursuant to the foregoing resolution, I hereby make the following appointments. Senators Coleman, Kuhn, Kupek, Senator Muhammad, and Senator Pa. That will be the committee who will escort the governor over. Remaining under the orders of business of motions and resolutions, Senator Kunis to designate special orders.
Mr. President, pursuant to Rule 26, I designate the following bill to be made a special order for immediate consideration. Members, the list is on your desk.
Members, special orders are on your desk. We will start with 166 on general orders. That is Senate File 2995. Senator Wiklund, the Omnibus Health and Human Services Appropriation. Senator Wiklund.
Thank you, Mr. President. I'm really excited today to be here discussing the HHS Omnibus, Senate File 2995. And before I begin, I do want to extend my thanks to some very important people who are actually integral into getting this bill put together, brought to the floor, brought through committees. First, I'd like to thank my committee members. Oh, thank you. Sorry. I will hold the mic closer. Members, first, I'd like to express some thanks for all those who have contributed to this very large bill. First, thanks to my committee, HHS committee members, Ranking Member Utke, Vice Chair Mann, Senator Bolden, Senator Hoffman, Senator Liskey, Senator Abler, Senator Morrison, and Senator Kupek. We had really very great conversations this session. I think we had respectful discussions of very challenging topics, and always it went very well, and very I appreciated the discussion that we had in committee. Next, I'd like to thank the department commissioners, Department of Human Services Commissioner Jody Harpstead and her team, absolutely essential to help us put this bill together. The Department of Health Commissioner Dr. Brooke Cunningham, thank you to her and her team. There are so many subject matter experts and agency folks. I won't name any names because I'm sure I would forget to name all of them, but I really appreciate all of their help. Also, MNsure Acting CEO Libby Cullum and her team has been essential in putting together the proposals. And Assistant Commissioner for the Children's Cabinet, Erin Bailey, and her staff has been so helpful and integral to putting together the children and families portion of the target. And in terms of our production of the bill, I want to say thank you to the Maine Health and Human Services revisers, Sandy Glass-Serrani, Alex Willie, and Dean Trefst. Countless hours over the last few weeks to put together this bill of hundreds of pages. And then from our Senate nonpartisan staff, Senate Counsel Lexi Stengel, Liam Monahan, Ali Hoffman-Litchie, Nolan Hadala. It takes four of them to work together with me and my team to work through this language, and then it's all its complexity. And essential in making all the numbers work, fiscal analyst Dennis Albrecht, absolutely critical to making this come together and to help make sure everything is balanced. In terms of my partisan staff, intern Josie Malloy, pages Andrew George, Sam Schachman. We had a huge number of bills we heard this year, over 150 bills, and to put together these committee packets and run a committee 3 days a week, it took a lot of effort from the pages, and I really appreciate all of that time. Senate partisan researchers, Larissa Fisher for the GOP and Emily Spiteri from the DFL, absolutely critical, again, to making our committee time run smoothly. And last, just want to thank my staff, Committee Legislative Assistant Haley Ryan and my Committee Administrator Anna Burke. Again, we can't put together these bills without hugely dedicated staff, and I want to express my thanks to them. So members, at first glance, it's easy to say or easy to look at this bill as just, another long and complex health and human services budget bill. Just like other long and complex health and human services bills that have come before. For those of you who have been here over the years, no matter the makeup of the body, there have been many. But this complexity is a reflection and acknowledgement of the profound responsibility our constituents have entrusted to us to build a state that works for and values everyone, and to boldly confront some of the most fundamental and oftentimes the most challenging questions that face us about how to protect and promote the health and well-being of all Minnesotans. I'm excited to speak today about our budget because we have the opportunity this year to do some transformational and life-changing things. In fact, there are a number of proposals in this bill that seemed almost impossible just a few years ago, and yet through the hard work, compassion, and persistence of so many, we have been able to craft a budget that puts many of our values into action. Before I get into some of the details, I want to make note that this budget is actually made up of two distinct targets. One package of proposals focused on children and families, and one focused on health and healthcare. But together, this bill represents a comprehensive budget that is based on a few key themes. The first is that Minnesota can and should be the best state in the country to have a family and raise a child. This budget lifts up and prioritizes our youngest Minnesotans to give them the best possible start in life and provides more tools and resources for families to ensure healthy pregnancies and support during those crucial years. It also recognizes the challenges families all over Minnesota face in finding affordable child care options. We know that a strong child care workforce creates the foundation for a strong Minnesota workforce. And for far too long, the programs and policies targeted toward children and families have existed in silos, overshadowed by numerous other competing priorities. This budget reimagines a state where the health and stability of children and families is always front and center. Second, all Minnesotans should receive the affordable and reliable health care they need. This means breaking down the systemic barriers that prevent Minnesotans from seeking care, targeting relief to Minnesotans who are struggling with high costs, including prescription drugs, and implementing concrete solutions for lowering the cost of care over time. It also means providing Minnesotans with more choices for affordable coverage and building equity into the framework of everything we do. It also means investing in our mental health system, our public health system, and our healthcare workforce so that we can prioritize things like prevention and ensure care is always available when it is needed most. And third, this bill does not shy away from the real work. We have set out to improve several of our systems and existing programs so they meet the needs of real Minnesotans. This is done through historic investments to modernize the basic technology and IT systems that deliver critical services to hundreds of thousands of Minnesotans every day, and removing harmful and unnecessary hurdles that prevent programs from adequately serving Minnesotans when they need it most. Further, several items in this bill focus on meaningful evaluation and oversight to ensure that we are making smart investments that fulfill all of their intended purposes. With that in mind, I'd like to highlight briefly some of the key proposals within the bills. In the area of children and families, I'd like to highlight that we have an increase to the child care, the CCAP program, to raise the rates. We have been struggling over the past decades with low reimbursement rates, and this bill will allow us to raise the rates for reimbursement to the 75th percentile. Members, that means that families will have more options to be able to choose from because there will be more providers interested in accepting these CCAP rates because they're closer to the regular rates they might charge. It means that families could have the potential of, instead of today where we're at the 30th percentile for kids over 3 years old and 40th percentile for infants and toddlers, where they might have 3 out of 10 providers they could choose from. And now if we raise this to the 75th percentile, they would have 3 out of 4 providers to choose from. It also addresses the child care workforce by investing in a retention payment program. During the pandemic, we had federal funding, which we were able to use to provide monthly stipends to child care providers of all types. And we have seen that this is one way we can bolster compensation in a field where wages are extremely low. We heard discussion yesterday about the long-term care workforce, and the child care workforce is similar. We have an average wage in Minnesota of around $13 an hour for many, many child care workers, and that's simply not enough to retain people in the field or attract them to see it as a career in terms of the development and education of our smallest, our youngest children. So the retention payment would offer an opportunity for providers to receive a monthly stipend, a monthly payment, and it will continue what we have in place today for the stabilization grant program. The bill also makes investments in addressing homelessness across the state. There's additional funding for the Homeless Youth Act, for supporting innovative programming, and also funding that will support work in metro counties that has begun during the COVID-19 crisis to be able to address homelessness, and this will help them continue their work. The bill also updates the foster care system to focus on early interventions and also makes an expansion in the definition of family that can qualify for child care assistance programs so that foster families will also be able to be eligible along with other relatives. In the Health and Human Services aspect of the bill, there's, as I mentioned, investments in public health. The Department of Health came forward with a strengthening or transforming the public health system report in January, and we were including funding to begin to implement this transformation of public health that involves the local public health agencies. This bill implements changes to fix the invisible barriers to health care. It sets the foundation to put in place public options so that we will begin to address the high costs of health care for Minnesotans. It expands access to health care for Minnesotans and raises rates for providers. There's a significant rate increase for mental health services, and that is an area that we know that we desperately need more providers to be in this field and to have them compensated appropriately. This bill ensures that communities of color across the state are directing the solutions to address racial disparities. There are grants and task forces that go to specific communities, and we know that to be effective, we need to involve members of the community in developing the solutions that we face, to problems that we face. And looking forward, we have a proposal to implement a healthcare affordability board to help us understand and grapple with our all of the costs of healthcare that go into that we are currently spending, to better understand them, analyze them, and then also to target some responses to that to try and contain the amount of increase in healthcare costs. With that, I will be happy to answer questions and entertain further discussion about the bill. Thank you.
Members, we're on Senate File 2995. Senator Uckey.
Thank you, Mr. President, and members. I would just like to go over some of the concerns that I have with the bill, and of course, the differencing of opinions and such. So I'll go through a short list, and then we will jump into some amendments that members have that will talk further about pieces of the bill that we either have issues with or would offer varying changes and such to make them better. But as I looked at the bill, I see it heavy with burdensome mandates, increasing costs to providers, increasing costs to the health plans, and a lot of oppressive policy. It also costs Minnesotans a lot more than $1 billion increase over the forecast. Currently, Health and Human Services combined spend over $70 million a day. How much more will this bill add to that? We don't know at this point. We should be talking about enhancing the quality of care and access to care, decreasing the overall health care costs, and strengthening our workforce. Unfortunately, I don't see that currently in the bill. Some of the concerning items that I and others will like to talk further about as we progress here today, the Keeping Nurses at the Bedside Act, the Healthcare Affordability Board and Advisory Council, school-based health centers, the managed care opt-out, and the extensive list of mandates and questionable grants. This bill includes new health insurance benefit mandates, and so does the Commerce Bill. The cumulative effort of both bills will add significant costs to the impacted markets, making health insurance less affordable for Minnesotans. The numbers I have at this time, and it does not include everything because not everything's got a price tag on it yet, would equal about $180 per month per family of four. That's additional cost in your health insurance. Again, that's not everything, only the things that I could find numbers on. If these coverage mandates are important, why are they exempted from the health plans used by legislators and the state employees, the plan commonly known as CGIP? Is there a reason, or is there a concern about the cost of premiums and for the state? There are 5 provisions in the bill which impact coverage. CGIP is exempted on 3 of them: infertility, rare disease access, and regulations on formulary charges. The fiscal impact on formulary requirements is projected to be over $30 million annually, starting in fiscal year 25. No fiscal notes were released for infertility or rare diseases, but based on industry estimates, each would cost the state millions of dollars annually. The motto of this bill seems to be mandates for thee, but not for me. Why are we treating Minnesotans differently based on where they get their health insurance? A term that I have questioned many times this year is social determinants of health. Members, you'll find that, or at least I found it, 5 times in this current bill, and I still don't find a definition, a defined definition for it. I believe that's important. As we all know in the business that we do here in this building, words matter, and we need to know what that means. A couple other things as we go through it that I've got. The 988 suicide and crisis hotline fee. I think everybody agrees it's a great plan, it's needed, etc. Just wondering about the numbers, and I hope that the discussion, maybe here today, but in conference committee, will follow up on that. There appears to be room for a lot of money to be raised, and I just hope that in the end, the amount that's being collected matches what is actually needed. And finally, there are some things in here that, again, pass cost onto our county governments, and I have a concern with that. When we pass legislation that sends what's commonly referred to as mandates to our county governments and we don't fund them, I would hope that we could do better than that, particularly at a time when we are spending this amount of money. I don't think we need to pass the costs along. So with that, members, I look forward to the discussion that we'll have going forward. And Mr. President, I think we've got somebody ready for an amendment. Thank you.
We are still on Senate File 2995. Anyone has any amendments? Senator Rasmussen.
Thank you, Mr. President. I would move the A59 amendment.
Senator Rasmussen moves the A59 amendment. The Secretary will report the amendment.
Senator Rasmussen moves to amend Senate File number 2995 as follows. Page 258 after line 8, insert. This is the A59 amendment.
Senator Rasmussen to your A59 amendment.
Thank you, Mr. President. I would request a roll call on the amendment.
Roll call requested, roll call granted. Senator Rasmussen.
Thank you, Mr. President, and I would also impose a call of the Senate for the duration of the amendment.
The Senate is now under call. Oh, I did. I'll do it again for you, though. Senator Rasmussen, just to be clear, this is just for the duration of the amendment, not for the duration of the bill. Is that right?
Correct, Mr. President.
Thank you. Senator Rasmussen.
Thank you, Mr. President. I move that further proceedings under the roll call be dispensed with and that the Sergeant at Arms be instructed to bring in the absent members.
On that motion, any discussion? All in favor say aye. All those opposed say no. The motion prevails. Senator Rasmussen.
Thank you, Mr. President. The amendment before the body is a bill that was authored by Senator May Quaid, Senator Kupek, Senator Hoffman, Senator Abler, and myself that would update the scope of practice for optometrists to better match the training that they receive in optometry school. The bill would allow Minnesota optometrists to prescribe oral carbonic anhydrase inhibitors, oral antiviral medications, oral steroids, and administer drugs by injection around the eyelid. The reason I'm bringing this amendment today is that Minnesota's outdated optometry scope prevents critical patient access to care in my area and across the state. I distributed a letter from a constituent named Danielle. Danielle has chronic eye issues and needs to take an oral antiviral medication. When she needs the prescription refilled for her daily oral antiviral, she needs to travel 6 hours round trip to see a specialist. That requires her to miss an entire day of work and costs her more money with an extra doctor visit and travel costs. In 47 other states, and I'll repeat that, in 47 other states, Danielle would be able to simply visit her local optometrist who leads her eye care. In her letter, Danielle says, "I plead with you to consider making access easier and allow my optometrist, who is trained and capable, to provide my care." Many Minnesotans have a similar story to Danielle's. Another issue, Mr. President and members, with our outdated scope is that it harms Minnesota's ability to attract and retain optometrists. There are currently no optometry schools in Minnesota. However, 24 of the 24 optometry schools in the United States teach beyond Minnesota's scope, which creates challenges for recruiting optometrists to come to a state where they can't practice what they've been trained for. It's also important to note that Minnesota optometrists have to pass national boards that cover 100% of the content in the amendment that is before the body. And I just want to give you a sense of how Minnesota compares to other states. 49 states allow prescribing oral carbonic anhydrase inhibitors. 44 of those states have no limit on the length of prescription. 47 states allow prescribing of oral antiviral medications without limit. 43 other states authorize optometrists to prescribe oral steroids, and 22 other states allow optometrists to administer drugs by injection around the eyelid. And the last point that I would make is that having this outdated scope costs Minnesotans more money for their care. In Danielle's case, she had to pay for an extra doctor visit and has to take days off of work to travel for a 5-minute appointment for care that in 47 other states could be administered by her local optometrist. So, Mr. President, members would ask for your support on this amendment to help increase access to high-quality eye care here in Minnesota.
Senator Wiklund to the A59 amendment.
Thank you, Mr. President. Yes, I am familiar with the amendment, and I am also in opposition to taking this amendment today and passing it. I have made a commitment publicly in our committee to hear this bill as well as other scope of practice and professional licensure bills in the next session. I think that the way that we should be proceeding with these bills is to have a full hearing where members can weigh in on their perspectives, what they're hearing from their communities, and we can have stakeholders present to us the information we need to make a fully informed decision. I don't think that doing this on the floor today with information that is read at our that's available to us is the way to proceed with this. And in fact, in committee, when we had the markup of the HHS Omnibus bill, I made a public commitment to the good senator from Lonsdale that I would hear this bill or others like it. There are two bills that are similar. That I would hear the bill next session and allow members to hear the full discussion before we make decisions about matters that do affect health directly, and I think members should have the opportunity to hear the full information before they decide. Thank you.
Senator McQuaid to the A59 amendment.
Thank you, Mr. President, and I just want to share a little bit about why I have this bill. Senator Rasmussen mentioned that I'm the chief author of this bill, and it's true that I am. I just want to provide some context about optometry and optometrists and this bill in particular. Optometrists are doctors of the eyes, and they can see so much of what's happening in our body through our eyes. The only look that you can get at the cardiovascular system without cutting into a person is through the eyes. Optometrists can see diabetes early. They can see Alzheimer's and dementia early. More people are comfortable going to see their eye doctor than they are seeing their primary care provider or their dentist. This is a critical piece of healthcare. And as Senator Rasmussen mentioned, we don't have an optometry school in the state of Minnesota. And so when students are graduating and looking to where they're going to practice, knowing that we are one of 3 states or 4 states who don't allow them to practice the full scope of what they have been trained and certified to do, we lose out on that, which means Minnesota Minnesotans lose out on this critical piece of healthcare. There are like 1,000 optometrists throughout the state of Minnesota, and we need to make sure that in every corner of the state, people have access to this really vital primary care. And so I just wanted to share a little bit of context about this bill, why I was chief authoring it, and how it came about this session.
Senator Uckey to the A59 amendment.
Thank you, Mr. President, and thank you, Senator Rasmussen, for the amendment. Coming from rural Minnesota and from rural areas everywhere, it really highlights the importance of what this amendment speaks to. We have the optometrists in a lot of our towns, but we don't have the ophthalmologists. And if we can get some of those services that the optometrists can provide locally, what a savings it is. We're used to driving. We do that all the time, but yet it's been said here on the floor already, and I know it because it's happening in my family, where they drive 90 miles for just a few minutes of a treatment or an exam when that could be done right in town. And so, members, this is extremely important for all corners of Minnesota, but in rural Minnesota, we really see the importance of this, and I would ask for your support. This can help out a lot.
Any other discussion before we go to the author of the amendment? Senator Rasmussen.
Thank you, Mr. President. I appreciate the discussion on this important topic today. I would just say, in terms of Senator Wiklund, and I appreciate her commitment to hearing this bill next year, but I would ask for member support on the amendment today for a few reasons. Number one, this bill has been out and introduced for a number of years, and I have a sense of urgency about getting this bill done because of constituents like Danielle, who, if we don't pass this bill this year, will have to go through another year of having to travel to receive high-quality eye care. Additionally, we'll lose another year of optometrists who decide to go to other states because they can't practice what they have trained for and what they have been tested on here in the state of Minnesota. And the other thing I just wanted to point out to members as they think about this amendment, nothing in this amendment permits optometrists to do anything that they don't already do in dozens of other states. And so I appreciate the conversation today and would appreciate support on the A59 amendment.
The Secretary will now take the roll. Members, please vote. Senator Bowden, for those voting under Rule 40.7.
Thank you, Mr. President. I report that Senator Dietzick votes no.
Senator Dietzick votes no.
And I report that Senator Gustafson votes aye.
Senator Gustafson votes aye. Senator Jasinski, for those voting under Rule 40.1.
Mr. President, Senator Lang votes aye.
Senator Lang votes aye. Members, please vote. We are under a call. No. Yes, we are. We're under a call. Everyone has to vote. Those not voting has asked to be excused. The secretary will close the roll. With there being 38 ayes and 28 noes, the A59 amendment is adopted. Additional, Senator Wiklund.
Excuse me. Thank you, Mr. President. I do have a technical, I have an amendment. It's the A69 amendment.
Senator Wiklund offers the A69 amendment. The secretary will report the A69 amendment.
Senator Wiklund moves to amend Senate File Number 2995 as follows. Page 149, line 10, after the period, insert. This is the A69 amendment.
Senator Wiklund to your A69 amendment.
Members, this incorporates technical changes that that need to happen to make the bill more correct. Lines 1.2 through 1.5 have to do with a study that we added in the Finance Committee on Monday. This is a study for the Nurses at the Bedside Act, and the study is to be conducted by the Office of Management and Budget, and there's some clarifying language that's added on lines 1.2 to 1.4 about the division of that would do the evaluation having access to relevant data. And then we wanted to make sure that the study had a better chance to collect data before being completed. We had in there 2027, and that really doesn't allow enough time for collecting data on the implementation of the Keeping Nurses at the Bedside Act. And so we are changing it now to 2029. We may change that again in the future, but that's where we want to get it to for today. Lines 1.6 through the end of the amendment have to do with a repealer that was inadvertently left out. So that is a technical change. Mr. President, if I could have a roll call, please.
Roll call requested, roll call granted. Senator Pratt.
Thank you, Mr. President. If I could just, if Senator Wiklund would yield for a question.
Senator Wiklund, will you yield? Senator Wiklund, will you yield? She will yield. Senator Pratt.
Thank you, Mr. President. I was just wondering if Senator Wiklund could maybe explain the repealers a little more in depth.
Senator Wiklund, to the question.
Mr. President, I will get the information and be able to respond more accurately.
No
Just
problem.
moment,
Take a
please.
minute. Senator Wiklund.
Thank you, Mr. President. I was told by staff that this repealer, the only thing that was added to this repealer, so you can see that the entire section was deleted and then this new section 47 is inserted. The only thing that is new language is the repealer for 245C.031, subdivisions 5, 6, and 7. Excuse me, and these relate to, or this relates to a proposal in the bill that transfers background check responsibility for conservatorships, guardianships to the BCA and away from the Department of Human Services. This is a Department of Human Services proposal, and that's the only change. The other part of the repealer language is the same.
Any additional questions on the A69 amendment? Seeing none, the secretary will take the roll on the A69 amendment. Members, please vote. Senator Jasinski, for those voting under Rule 40.7.
Thank you, Mr. President. Senator Lang votes aye.
Senator Lang votes aye. Senator Bowden, for those voting under Rule 40.7.
Thank you, Mr. President. Senator Dietzick votes aye.
Senator Dietzick votes aye.
And Senator Gustafson votes aye.
And Senator Gustafson votes aye. All senators having voted who desires to vote, the secretary will close the roll. There have been 52 ayes and 10 noes. The A69 amendment is adopted. Any additional amendments? Senator Pratt.
Thank you, Mr. President. I'd like to offer the A75 amendment.
Thank you so much. Senator Pratt offers the A75 amendment. The secretary will report the A75 amendment.
Senator Pratt moves to amend Senate File Number 2995 as follows. Page 4, after line 17, insert. This is the A75 amendment.
Senator Pratt to your A75 amendment.
Thank you, Mr. President. When we were in finance, we debated a prompt payment amendment, and I appreciated Senator Wiklund's agreement to work between Finance Committee and now, and her efforts to connect with the agency to come up with language that would, in fact, reinforce the prompt payments that DHS is required to do. I understand this should be a friendly amendment, Mr. President, so I encourage all members to vote yes.
Senator Wiklund to the A75 amendment.
Thank you, Senator. Thank you, Mr. President. Senator, it looks like this is, I believe, the language that we discussed yesterday, and I worked with the department on this language. I believe that they find this acceptable. It still keeps, they're following the Code of Federal Regulations as they need to as a state agency, but I think it gets to the questions that you raised in finance, and so I would accept the amendment.
Did you say at the end your vote?
I would accept this as a friendly amendment.
Thank you, Senator Wiklund. Senator Friends.
Thanks, Mr. President. As Senator Wiklund has said she would accept it as a friendly amendment, I'm not requesting a roll call.
Thank you so much. Any additional questions? Any other discussions? Seeing none, all in favor say aye. All opposed say no. The motion prevails and the A75 is adopted. Any additional amendments? Senator Gustafson. I'm sorry. Senator Gruenhagen.
Honest mistake, right?
I know you look nothing alike. I'm sorry. Senator Gruenhagen.
Oh, thank you, Mr. President. Yeah, I'd like to offer the A63 amendment.
Senator Gruenhagen offers the A63 amendment. The secretary will report the A63 amendment.
Senator Gruenhagen moves to amend Senate File Number 2995 as follows. Page 559, delete Section 16. This is the A63 amendment.
Senator Gruenhagen to your A63 amendment.
Well, thank you, Mr. President. Yeah, what this amendment does, it deletes in the bill the study for single payer, Minnesota Care, and the public option buyout, and instead takes the money for those studies and puts it into school-linked mental health grants, which we have a crisis with in this state as far as our young people. That would move about 11 million and some change in 2024 over to a school-linked mental health grant, and in 2025 it would move almost $13 million to a school-linked mental health grant where it's desperately needed. Now, one of the reasons that I offer this amendment and want to delete these studies is we have overwhelming evidence that the lower reimbursement rate on these plans already seriously restricts health care access in our state. And members, we know that health care access for our citizens and children is one of the most important things that they can possibly have. Because when you suffer from a sickness or accident, you want good health care. My concern is, members, that this bill and these studies actually take us in a direction to restrict health care access and will, if implemented, would actually hurt our health care access at hospitals and doctors here in the state. Now, there's a couple letters you received, one from NFIB, and it says, public option, we'll start with the public option. Public option is likely to shift cost onto the already overburdened small group and individual market due to its reliance on government-level health care provider reimbursement. They go on to say, lower reimbursement rates from these, single-payer Minnesota Care and public option will make healthcare delivery and access to care in rural areas especially, that there is already a severe shortage of providers of the types of healthcare that we need, according to the Minnesota Department of Health. So that's not even our NFIB's opinion. The Minnesota Health has said that. So members, we're going in the wrong direction with these studies. Now, it also is in the Minnesota Chamber's letter that issues similar types of concerns for the reimbursement rate of Medicare, Medicaid, and Minnesota Care as far as our doctors and hospitals. And members, I was a part of passing a plan for healthcare transparency a couple of years ago. If you go into your clinic anywhere in the state, you're going to see that we passed a bill that requires them to post the 25 most used healthcare procedures and their cost in relationship to what they charge, what commercial insurance reimburses, what Medicare reimburses, and also what Medicaid reimburses, which is what Minnesota Care is based on. I'll just give you a couple examples, member, but I encourage you to go into your clinic. They're required to post this information, and I simply went in and asked for a copy. For instance, under a lab test, in my area, the charge is $135.84. Commercial insurance reimburses at $70.31. Medicare reimburses $58.57. Medicaid, which would be also Minnesota Care, reimburses $14.88. So members, your doctors and hospitals cannot exist on a $14.88 reimbursement rate. Then a hemoglobin lab test. My area charges $98.50. Commercial insurance reimburses $50.99. Medicare $42.47, and $10, and Medicaid $10.79. Members, the expansion of Minnesota Care and single payer, which will be based on Medicaid rates, is going to seriously hurt access here in the state of Minnesota. The last one I'll give you is a thyroid lab test. My clinic charges $170.45. Commercial insurance reimburses at $88.23. Medicare at $73.50. Medicaid, again, Minnesota Care, Medicaid, single payer would reimburse at $18.67. So members, expanding Minnesota Care, going to a single payer plan, is going to hurt access in this state, not increase it. You'll have a card that says you have health care, but there won't be access for you to take advantage of it. So there's also an article a couple years ago in the Star Tribune, a front page article. It was titled, "Rural Hospitals Are Hanging On, but Just Barely," okay? And then I was surprised that in the article, which I have a copy of, they actually implicated low reimbursement rates for Medicaid plans and also Medicare, and that there's a growing number of more and more people on government health care and less on commercial insurance. And those clinics and hospitals cannot exist on the low reimbursement of Medicare and Medicaid. So members, what this does, we also, by the way, and NFIB does a good job on this, they tell you Washington's tried the public option, and it hasn't worked. It's had lots of problems, and they had to stick another $50 million to try and keep it going. I also have articles, fewer and fewer hospitals are buying into the public option because they can't exist on the low reimbursement. Colorado has tried the public option. They also are having problems, and only 13% of the state's individual market participate in the public option. So members, this is a critical issue for our citizens and children, and we're going the wrong direction, spending, almost $24 million, or over $24 million, on studies that we already have the results on. Now let me just move to single payer.
Senator Gruenhagen, I just want to make sure that we're still on your A63 amendment, because it sounds like we're going through the bill, and I'm not certain that your A63 amendment goes through the entire bill. So there's comments that you can certainly make on third reading, but I would just encourage us to be focused on the A63.
Yeah, Mr. President, the amendment deletes the studies for Minnesota Care, single payer, and the public option. So my comments have been concentrated on those three areas.
All right, continue.
Okay, let's go to the single payer. Again, members, we don't need to spend millions of dollars on something that's already been settled. We're talking about low Medicaid reimbursement rates. We have, in 2011, Vermont passed a single payer plan, all right? All they had was trouble with it, and higher taxes and less access. So you know what Vermont did in 2014? They abandoned this single payer plan, okay? Then we have California. California looked at implementing a single payer plan in 2017, but they looked at a minimum price of $400 billion to even start it up. And the result is, the governor said at that time, who was Jerry Brown, said, single payer, you're simply making a bigger problem even bigger. It makes no sense. And he was a Democrat in terms of implementing this. So members were simply taking this money, and rather than putting it where it should be with the mental health crisis in our schools, we're moving it to do studies that the evidence has come in already. And unless you want to see less access for the citizens of the state of Minnesota and their children in terms of health care, because that's the direction you're going in this plan. Finally, members, we have horrific stories on single payer of waiting periods, and I happen to know a doctor who used to be a Canadian doctor and believed in single payer, and he moved to the United States because he wanted to get away from it. He was tired of begging for money to update his equipment, and he even wrote a book about it. The end of the American Revolution, if you want to so purchase. He's right here in Minnesota. We have the horror stories in England to go on top of this. So members, I know mentally or even feeling-wise you think, well, we'll just give everybody access. not with government low reimbursement. You need a vital, robust private health sector in order to bail out the losses from government programs. That's why when we initiated the government programs back in the late 60s, we had a vibrant, productive private group and private individual market health insurance. And they were able to bail out the losses from Medicare and Medicaid over the years. That's why your premiums were going up 10 to 12% because of the cost shifting. So members, I beseech you, think about what you're doing here. Think of what even the Star Tribune and Democratic governors say about going down this path. And again, we're talking about over $24 million in the next biennium that actually could address some of the crisis that's in our public schools. So members, I hope you can vote green on this. And Mr. President, I would ask for a roll call.
Roll call requested, roll call granted. Senator Friends. Senator Marty.
Thank you, Mr. President. I didn't look through every provision that Senator Gruenhagen has in his amendment, but he did spend a big chunk of his time talking about sections 27 and 28, which deals with the universal health care system, which I've authored a bill on for a number of years and proposed this study. And first of all, I will assure you that nobody has conducted a study of this nature before. Nobody has tried to propose a system like this before, and you're making a lot of pretty wrong assumptions in your statement. And like what Vermont, what you called a single payer system there, might have covered about a third of the people of Vermont. It wasn't. It's not anything like what we're proposing. We're proposing a universal health care system. And in terms of the reimbursement rates, well, it'll track Medicaid rates or Medicare rates or whatever you were saying they would track. We explicitly have in the bill language pointing out that the assumptions they should make are that we're not going to be tracking any of those. We discuss how it would work. This would discuss all the issues you are convinced you've done the research on, and I'm glad you've done the research, but frankly, nobody's done the research, so you're quoting people who haven't done the research. So I'd urge members to reject this, and let me tell you, I very much understand the concerns of rural hospitals, both in low reimbursement rates and other things. When Mayo decided to shut down the hospital in Fairmont, it wasn't because there was a lack of need there, because it didn't fit into their business model. Same thing they did in Albert Lea. Had nothing to do with single payer. It's the current system that's driving them out of business. And frankly, the whole system is, I've talked to people who can't get to visit with a primary care doctor for a month or two. The system is getting worse. And we are spending more than twice as much per person in this country for health care than, with maybe 10 exceptions, any other country in the planet. And of the 7 or 8 or 10 that may pay more than half what we do, they're a lot below us. They're just more than half. And our outcomes, heard again an analysis this morning about how our life expectancy is way below other comparable wealthy countries. Our outcomes are worse, our costs are much higher. And frankly, the only way we're going to have rural hospitals survive, the only way we're going to improve access to care is by having a system that thinks those things through and covers it and requires it. Our bill would require the plan to make sure that all hospitals can have the funds they need. Would budget in a logical way. It would take away the huge boatload of bureaucracy that we spend, the time that doctors and providers spend filling out forms, all the medical data we track. It's a terrible waste of everybody's time and money. And frankly, if you're so convinced that this is a bad idea, you should welcome the study because it'll prove you right. But the reality is it's not going to prove you right because that's not the way it works. We are, every time we try and do something new, and the insurance, oh, that's just wonderful. They come up with all kinds of ways to save money. Networks, Then they tighten up the networks, and so half the providers you see are out of network. Co-payments and deductibles, they keep going up and up. The current system is broken. Got some of the best medical providers in the world, some of the best research and technology, but the most dysfunctional system on the planet. And that's why having a logical healthcare system would make some sense. But I urge you to read the language and what they're studying and how they're studying it, because frankly, nobody's done a study like this in the past. And those who say it doesn't work, well, they don't even know what we're talking about, because they haven't proposed it in any of those places where you claim that they've been trying it. So I urge members to reject this. I'm speaking primarily about those two provisions because you spent so much of your time on that. But I think the bill is a good bill, and I urge you to reject the amendment.
Members, if I can gently remind you that we're on the A63 amendment, and let's stay focused on the A63 amendment. Senator Wiklund.
Thank you, Mr. President. I would request that members vote no on this amendment. While I do agree very strongly that school-linked behavioral health grants are important, and I have been a co-author on bills to provide more funding for those, I am not willing to lose these parts of this bill that I believe are really important in terms of setting a course forward for affordable, accessible health care. Removing the public option, it is designed to help people who are currently cut out or priced out of affordable health care coverage by giving them an option of enrolling in a program where they pay a sliding scale premium based on their income. The work to design this and implement it will require some study and some investigation so that we do get provider payment rates correct. And the bill includes a delivery transformation study to evaluate our current system against other options. It includes assessing provider reimbursement and includes other impacts that health plans have on disparities in our state, racial disparities, geographic disparities, and costs. So the bill includes the requirement that these things are studied before we implement, and I believe they address key concerns that Senator Marty has alluded to in terms of people not being able to afford to use the health care, the health insurance that they currently purchase. And we need to be doing something about that starting now to help people be able to afford to use their health care. So I would ask members to reject the amendment. Thank you.
Senator Dames.
Well, thank you, Mr. President. I just wanted to stand and rise on supporting this amendment. Just want to talk a little about the single payer and government-run health care. I think most of us remember the Obamacare days, and there was a lot of promises made at that point, but there was a lot of things that looked that they could logistically work out pretty well. But as we all remember, at the end of the day, it didn't work that way. One of the first things that happened is we had rates that went sky high. The rates almost went up twofold almost instantly. We had folks that were typically used to a $250 to $1,000 deductible. Pretty soon they found themselves paying a $2,500 to a $5,000 deductible to try to get the rates somewhat reasonable compared to what they had been. But you know, that's history. We came up with a program to solve that problem, and it was called reinsurance, and that problem has worked very well. Now, does that mean that we should not look at some new avenues? Probably not. But let's keep in mind the things we did learn. We don't have to reinvent the wheel on several things that we learned when it come to the Obamacare era, when it come to what happened to health insurance and what that caused, and what type of problems it did put forth. One of the first things that happened, and if we can remember back in 2017, 2018, one of the first things that happened is we run out of insurance carriers willing to provide policies into a lot of our various counties. So for a year there, a lot of these folks could not find insurance coverage. We then came along with reinsurance, and within a year, we had nearly every county had at least 3 insurance companies providing more than 2 policies. The point of this conversation, in my opinion, is what's going to happen when we go to including Minnesota Care for All. We have to remember what some of the end results are going to be. And let's take a look at the rate structure. Currently, Minnesota Care pays pretty much Medicaid rates. So if we're paying Medicaid rates versus Medicare, there's probably a 25% difference there, 25 cents on a dollar. Then we go to insurance rates, and insurance rates are in that 68 to probably 72 cents on a dollar. And if you look at Medicaid, you're probably in that 25 to 28 cents on a dollar. So you're somewhere in the neighborhood of 50 cents, not quite 48 cents on a dollar difference in the pay. So if your real concern is providing the best coverage at the lowest price, then we would equalize everybody and everybody would pay the same. Whether you're on Medicaid, Medicare, or insurance, you'd make the same payment. But let's face it, folks, that would not work, because that would reduce the amount of money coming in to the hospitals and to the providers considerably, because so much of it is under the insurance side of it and get paid the higher rates. So the rate structure is also a problem. So what's going to happen if we go to really expanding Minnesota Care for All and we start working toward a single payer process? What's going to happen is we're going to have our rural hospitals that are going to lose the insurance side of it and end up with a lot more folks on Medicaid, and our rates are going to go down considerably, and that's going to put a lot of these hospitals in a severe financial problem. So I think before we move ahead, and there's a lot of language in this bill to deal with that, and I think before we move ahead to do that, I think we need to really take a strong look at where we want to go, see where we've been, and see what the consequences of where we've been and what that's done. So with that said, members, I would encourage a green vote.
Senator Abler.
Thank you, Mr. President, and like a laser, Mr. President, I just want to comment on one part of the bill where that talks about taking away some of the reliance on Minnesota Care. And in theory, it sounds, well, how could that not be great? We got Minnesota Care, and it could be for Minnesotans, and then they'd be cared for, and it's reasonable, and gee, it's cheaper than my regular plan, and like, holy buckets, this is like the answer, like just the light bulb goes off. But I want to caution people, the reason it's so inexpensive is because it's a cheap product. It doesn't actually work if everybody in Minnesota has to take it. The rates are similar to medical assistance rates, in some cases identical, which in cases of clinicians like myself, it hits about cost. If you happen to be a dentist, it hits below cost. And the only way to do a lot of business at below cost is to make it up in volume. Actually, Mr. President, that doesn't work. That's a remedy for going out of business. And by the way, if you have Minnesota Care or medical assistance, try to find a dentist. God bless their hearts and their passion for service. God bless their efforts, but try to find one who can take you for your care needs. And there's some efforts in the bill to raise the rates. That's been an ongoing challenge, but Minnesota Care as it stands is not the answer to solve the people's care needs. It is better than nothing, but if everybody has it, like Senator Dames mentioned and others, the rural hospitals will not be able to stay open. They can't afford Medicare rates. And so if we funded Minnesota Care at Medicare rates, that would be considered a much bigger improvement, but it would be a huge fiscal note, which is why it's not a great idea. And so and that this bill, and rather than expand Minnesota Care, puts some money into mental health grants for students in schools. And so that's the choice, and the debate is bigger than what do you want to buy, this or that, although in this bill there's many choices of things you could have bought different than what we bought, and I'll talk about that more on third reading. But Mr. President, I just want to be aware to people to rely on Minnesota Care. Thank you.
Senator Pratt.
Thank you, Mr. President. I'm going to disagree with some of my colleagues that have been talking about our healthcare system. I think we have some of the best healthcare in the world. Minnesota has some of the preeminent clinics on the globe. We have people coming here. Minnesota is a destination for those who need the best care available. Members, we offer hope to the hopeless and we save lives. Our budget bills are a reflection of our values. We have, as Senator Dame said, we have some of the lowest rates in the country thanks to his efforts on reinsurance. Now, the Affordable Care Act, as he mentioned, was meant to keep health care costs down, and we saw insurance rates explode. We don't know what a Minnesota Care buy-in will look like. But what we do know, Mr. President, as I've heard in the hallways, is there is broad agreement that we need more support for school-linked mental health. It's one of those issues that seems to cross the political divide. Our kids face pressures today that we never knew. So I want to thank Senator Gruenhagen for bringing this amendment forward. Members, we have an opportunity to put our values and to put our kids first in this bill by investing in their mental health. And I urge a green vote.
Members, I want to make sure that no one else wants to speak before we give the author of the amendment the last word. Seeing none, Senator Gruenhagen.
Oh, thank you, Mr. President. Yeah, thanks for the discussion, members. You know, when I hear Senator Marty, and I know he means well, there is a couple areas that I do agree with him on. The bureaucracy we have created, government has created, is one of the main problems of waste, fraud, and abuse in our healthcare system. Just do any type of research on it. Now, if you do research, you'll find that in 2021, and this is off the top of my head, I think nationally we spent $4.3 trillion on healthcare in this country, an enormous amount of money. But almost a third of it, over $1.3 trillion, was bureaucracy to micromanage the doctor-patient relationship. And what Obamacare did, it simply bloated the bureaucracy. It made it 10 times worse than what it was. And what you're seeing is narrower networks, less reimbursement to doctors and hospitals, and members. Remember the promise of Obamacare, which turned out to be false? We're going to have access for everyone. Well, it was presented in the other body when I was on the HHS committee back in 2018. There was a 2017 study here in Minnesota in terms of access for people for needed health care, not what they wanted or desired, what they needed, okay? And you know what the study found? 1.2, this is after Obamacare and all its promises, 1.2 million Minnesotans did not seek needed health care due to the high cost and deductibles. That was the conclusion. So all Obamacare did was bloat the bureaucracy and push micromanagement of our doctor-patient relationship. Now, if you want to replace that bureaucracy with a government bureaucracy under a single payer, it'll be worse than the current bureaucracy. And I do have an amendment in the future to address that, okay? We have an option to address the bloated bureaucracy, and we'll get to that later. But members, the evidence is in on single payer, whether you want to accept it or not. The low reimbursement, and again, we have a great healthcare system in this state, just great. But the further we go down the road of weakening the private sector healthcare, group and individual, which we got rid of the reinsurance money in one of the previous bills, the more we go down that road of weakening the private insurance, which is necessary, a robust private insurance market is necessary to bail out the losses from the government reimbursement plans. As long as you have a robust private health insurance market, it works. And we had that with the baby boomers. The problem is we have a demographic change, and the baby boomers are now retiring. And we're increasing government reimbursement, and we're hurting the private health insurance market, and Obamacare was a big step in the wrong direction. So members, please vote green for better access and protecting our healthcare system. Oh, one last comment. I wrote a book, Healthcare in Crisis, Is the Government the Solution or the Problem? I'll give a free, I used to charge $5, but I'll give it away free now.
Senator Gruenhagen, this is not a time for an advertisement.
What? Well, Mr. President, it explains everything that I've just talked about in much more detail.
All right.
The other thing is a couple of years ago, actually it was over 4 years ago, the president of Rochester Mayo Clinic was quoted on the front page of the Star Tribune, and I cut the article out, that the Mayo Clinic was seriously considering not accepting reimbursement from government programs. Did you hear that, members? The president of the Mayo Clinic was quoted on the front page of the Star Tribune as telling, when he was in Washington, D.C., stating that they were seriously considering not accepting patients with government reimbursement. That should be a red flag for all of us in terms of access. We've got a wonderful healthcare system, but when we go down the road that's in this plan and what I'm trying to remove, we are wasting money and we're headed in a direction with less access of healthcare for our citizens and our children. Please vote green.
The secretary will take the roll. Members, please vote Senator Bowden for those voting under Rule 40.7.
Thank you, Mr. President. Senator Dietzick votes no.
Senator Dietzick votes no.
And Senator Gustafson votes no.
And Senator Gustafson votes no. Members, please vote. Senator Jasinski for those voting under Rule 40.7.
Thank you, Mr. President. Senator Lang votes aye.
Senator Lang votes aye. All senators having voted who desires a vote, the secretary will close the roll. There being 31 ayes and 34 noes, the A63 amendment is not adopted. Any further amendments? Okay. Senator Gruenhagen.
Oh, thank you, Mr. President. This one I think will be a little shorter, but I'd like to introduce the A64 amendment.
Senator Gruenhagen offers the A64 amendment. The secretary will report the amendment.
Senator Gruenhagen moves to amend Senate File Number 2995 as follows. Page 207, delete Section 51 and insert. This is the A64 amendment.
Members, just reminding you that when you have your amendments, there are two things I want you to remember. A gently reminder of Rule 401, and just to make sure that our comments are based on what is before the body. Senator Gruenhagen, to your A64 amendment.
Oh, thank you, Mr. President. Yeah, what this amendment does, it eliminates the school-based health clinics and puts the money into school mental health grants to our public schools. Again, this would move, by eliminating this school-based health clinics, it would move another, in 2024, almost $1.5 million to our public schools, and in 2025, it would move almost $2 million to our public schools to address mental health, which is at a crisis for our students. Okay? Now, why am I concerned about a health clinic in a school? Do I oppose a nurse? to be able to address a health problem. No, when I was in school, I actually had to go to the nurse a couple times because I got sick at school. So I'm not against that. But what we're talking about here is to create a medical clinic inside the school. And here's the concern, members. When I was on the school board, and this actually happened, there was a 15-year-old young girl that was attending the school district that I was in. She was referred by the school over to a neighboring town's medical clinic. That clinic did an STD and a pregnancy test on that 15-year-old girl. They then mailed the bill to the mother and the father from that clinic. When the mom got it, she saw it was addressed to her daughter, and keep in mind this is a 15-year-old girl, and she opened it from the clinic, and here was a bill for STD and pregnancy tests. So she called up the clinic and asked them, was my daughter over there receiving medical care, my minor daughter, without my knowledge? And the response, according to the mom who talked to me, said the clinic told her, who was that bill addressed to? And she said, my daughter. And the person at the clinic said, what are you doing opening your daughter's mail? This is on a minor girl, members. This happened while I was on the school board. The parent then called me, and I came involved, and I actually brought it as an issue to our local school board, who didn't want to talk about it, but they did anyway. So, members, what we have here, again, I'm not against a nurse, but what we have here, by developing these clinics in the schools, we have students who will be going to these clinics, and my strong concern is that they're going to be doing medical procedures on these minor children without parental knowledge. Members, I've already seen it happen, so we should not be going down this direction. If the nurse needs to refer a child for health care, they usually call the parent, or they'll give them a ride to the local clinic, or they'll call an ambulance if something serious happens. Everybody supports that. But here we're taking a broad step of giving a lot of medical care made available to students, and in many cases, my strong concern is there is no parental knowledge or input, but yet they'll get the bill and the responsibility out of this. So members, I ask you, vote the money. Again, it's almost $1.5 million in 2024 and almost $2 million in 2025. Let's send it to our schools to address the mental health crisis, which they desperately need. Thank you, Mr. President, and please vote green, and I do ask for a roll call.
Roll call requested, roll call granted. Senator Wiklund.
Thank you, Mr. President. Members, please vote no on this amendment. School-based health clinics do provide essential services for the student population that is tailored to their population, and they promote teen-centered health care, provide accessible health care to all regardless of ability to pay, and they ensure confidentiality in health care for adolescents and young adults. They increase the focus on mental wellness, and they increase access to mental health services and supports. While again, the school-linked behavioral health grants are important, this funding for school-linked health clinics is something that we should be including funding for in the bill, and I would urge members to vote no.
Senator Murphy.
Thank you, Mr. President and members. This issue is an issue that I have worked on for years, beginning in my early work with the Minnesota Nurses Association. Nurses have often supported school-based clinics. They are not a new phenomenon in the state of Minnesota. I'm delighted that it is in this proposal. A clinic based in a school means students have access to needed health care, basic primary health care, and they are able to access it while they are learning, which improves learning and health. I did want to make sure and share with everybody information about consent, since Senator Gruenhagen raised that. And I am reading from a research document based on the law here in Minnesota. A minor may not receive health care services without consent of a parent or guardian unless an exception applies. There are just 3 exceptions: emergency treatment, a minor who is married or has given birth, and a minor who is living apart from parents and managing their own financial affairs. Those are the very rare exceptions, and in every other case, the student that accesses care in a school-based clinic needs consent from their parent, and nurses take consent incredibly seriously. It is a part of our licensure, it is a part of our discipline, it's a part of our practice. These school-based clinics honor that. They are important for students, for their health and their learning, and that's why this is important, and I'm supporting it. Please vote no on this amendment.
Members, any other comments before I go to the author of the amendment? Seeing none, final words, Senator Gruenhagen.
Oh, thank you, Mr. President. Yes, thank you for those comments, Senator Murphy. And my concern is also in the bill, there's going to be a lot of nonprofits who have access to our
Senator
students.
Gruenhagen, we want to stick to your A64 amendment. You have more than enough time to talk about what's in the rest of the bill. I'll certainly give you as much time as you want, but right now it's your A64 amendment.
Yeah, but it relates to the health clinics in terms of the access of the nonprofits that are going to
Okay.
be having access.
Go ahead,
The
Senator
other thing, it's going to be so easy to give health care to minor students without parental permission. I'll go back to my example again, where the 15-year-old was referred to a neighboring clinic by the school. The parents weren't informed. She was living with the parents. None of those exceptions applied. Actually, if she was below the age of consent, it should have been reported to the police as statutory rape. Instead, it was just all brushed under the carpet. So I appreciate the assurances Senator Murphy brings, but my experience has proven otherwise. And putting these clinics, along with nonprofit access, which we don't know what they're going to bring into those clinics, is a formula for unhealthy behavior being reinforced in our schools to our children at a time where they need strong message on their health and their safety. So members, please vote green and let's move the money to where it's needed, the mental health grants.
The Secretary will take the roll. Senator Bowden, those voting under Rule 40.7.
Thank you, Mr. President. Senator Dietzig votes no.
Senator Dietzig votes no.
And Senator Gustafson votes no.
And Senator Gustafson votes no. Senator Jasinski, for those voting under Rule 40.7.
Thank you, Mr. President. Senator Lang votes aye.
Senator Lang votes aye. All senators having voted who desires to vote, the secretary will close the roll. There being 31 ayes and 34 noes, the A64 amendment is not adopted. Senator Liskey.
Thank you, Mr. President. Mr. President, I would like to move the A67 amendment.
Senator Liskey offers the A67 amendment. The secretary will report the A67 amendment.
Senator Liskey moves to amend Senate File Number 2995 as follows. Page 208, line 14, after A, insert school-based health center services. This is the A67 amendment.
Senator Liskey to your A67 amendment.
Thank you, Mr. President. Mr. President, as we heard here on the floor just a little bit ago, we were discussing parental consent with concerns towards consent of minors and different health care situations. We've offered something similar in committee. Expression there was that it wasn't worded well, it was going to interfere with certain things. So this amendment is strictly based on already existing legislation and law. Here it would just make the school-based health centers adhere to already existing law in regards to consent of treatment of minors.
Senator Wiklund to the A67 amendment.
Members, Mr. President, I would urge a no vote on this amendment. The current practice, the school-based health clinics have to comply with all existing consent laws, and we don't need to put in a duplicative statement reiterating something that is already the case.
Senator Friends.
Thank you, Mr. President. I'd like to request a roll call.
Roll call requested, roll call granted. Senator Abler.
Thank you, Mr. President. I think we don't often enough call attention to some of the unsung heroes of the Senate. And Senator Friends has done yeoman's work on requesting roll calls time and again, and I just commend him again for noticing that. So on this matter, Mr. President, in committee, when we asked this very question, the answer was actually very equivocal. And like, well, I'm sure it's going to be fine. Well, and I asked some specific questions which could not be answered, I believe, by the advocates who they're promoting this. And so, Senator Wiklund, if this is truly meant to codify a current law, and would Senator Murphy yield for a question, Mr. President?
Senator Murphy, will you yield? Senator Murphy will yield. Senator Abler.
Well, thank you, Senator Murphy. I do a lot of comfort from what you said about how they have to abide by the laws of current consent, which are a little confusing, but they exist, and everyone has been slogged through. Some have been tested by court cases, some have been kept, some have been thrown out. And so, Senator Murphy, where is a school clinic governed? If we don't adopt this amendment, where does it say what a school clinic can do relative to consent of a minor for whatever procedure that might come up?
Senator Murphy to the question.
Thank you, Mr. President and Senator Abler. I believe the law is clear around consent, and it is that law that would guide those decisions by providers for the patients in their care.
Senator Abler.
Thank you, Mr. President. That was the answer I was hoping for in committee. And it did not come that way, and I totally respect Senator Murphy's expertise on this. She has a career in this, and confident that she's telling us what's correct. My concern is, and the reason I think Senator Wiklund, if you could just accept this as friendly, it's not meant to be clever or anything hurtful to the bill. It's just meant to simply clarify that in practice, sometimes things get away from what we're to do. And in terms of, we have laws on what we can provide for economic supports. And there's a list of rules, and sometimes the new person doesn't know the rules, and some other places they just maybe want to ignore them. And people get what they should get, or they don't get what they should have got because the person was uninformed. And so I'm very concerned that given the scope of things that might be going on at this clinic, which could be any number of procedures that could range from the tear a fingernail to counseling for abortion, to counseling for other healthcare affirming services that might come up. And it's just important to think that we keep these focused on what they are. And I think a lot of us are happy to have students get health care at places like this, so it's handy, because some of these undertreated conditions can actually be really very bad. But that would just make this bill be what it is. And so, members, I would urge a yes, and I ask Senator Wiklund to reconsider that this could just not go in the bill as comfort language. Thank you.
Senator Wiklund, are you standing to say something? Okay. Any other discussion before I go to the author of the amendment? Seeing none, Senator Litsky.
Thank you, Mr. President. Mr. President, again, I urge members a green vote here. As Senator Abler has referenced, this is more of a comfort language. Reading through the bill, I get concerns with no language describing consent at all through school-based health centers. And being that they're new, I'm not sure how they would fall under current law with consent. And so that's why I have offered this as an amendment. Thank you. I urge a green vote.
The Secretary will take the roll on the A67 amendment. Senator Bowden, for those voting under Rule 40.7.
Mr. President, Senator Dietzig votes no.
Senator Dietzig votes no.
And Senator Gustafson votes no.
Senator Gustafson votes no. Senator Bowden, for those voting under Rule 40.7.
Mr. President, I also report that Senator McEwen votes no.
Senator McEwen votes no. Senator Jasinski, for those voting under Rule 40.7.
Thank you, Mr. President. Senator Lang votes aye.
Senator Lang votes aye. All senators having voted who desires to vote, the Secretary will close the roll. There being 33 ayes and 34 noes, the A67 amendment is not adopted. Senator Nelson.
Thank you, Mr. President. I have the 101 amendment.
Senator Nelson offers the 101 amendment. The Secretary will report the 101 amendment.
Senator Nelson moves to amend Senate File Number 2995 as follows. Page 258 after line 8, insert. This is the A101 amendment.
Senator Nelson to your A101 amendment.
Thank you, Mr. President. Well, it is well known in this body and across the state that we have a significant, dangerous shortage of nurses. And we also know that there's a backlog in the Board of Nursing Licensing Department. This amendment, members, would allow Minnesota to join the Nurse Licensure Compact. It is a smart change that benefits both patients and nurses. It's a win-win that increases the number of available nurses for medical providers so they can provide high-quality care for patients across the state. Members, it's good for nurses. By joining the compact, we can make it easier for nurses that move to Minnesota to work and care for their patients. And that means a highly mobile economy like ours, people who are already trained and licensed in other states can move to Minnesota and not have to go through the complex licensure hurdles to do a job for which they have already been qualified. Just to give you some numbers, members, I think facts are always important. There's about 200,000 registered nurses in Minnesota. 200,000. Now, a very small percentage of those, about 10.1% to be exact, 22,000, belong to the Minnesota Nurses Association. Now, according to a survey from the Minnesota Board of Nursing, 78% of Minnesota nurses with an active license support our state joining the compact. You know, and it's especially good for military spouses who move from state to state and often don't have the time to go through the red tape of their as they are soon to be deployed to another base. Secondly, members, joining the compact is good for patients. It simplifies the ability of nurses who are working with patients across state lines. Can you think about that? Can you think about telehealth and how it has been so important at the time of COVID and beyond? Joining the compact is good for patients. It allows for traveling patients seeking care in Minnesota at our world-class institutions to be able to continue that care and stay in touch with their nurses when they head back to their home states. And just so you know, in 2015, Minnesota already has adopted and allowed the physician medical compact licensure. Why would we not do the same for our nurses? It will also increase the number of people available to work in Minnesota. As we know, this will help with the nurse shortage, and it will provide immediate increase in the number of people who could apply for jobs here. Joining the compact is safe for patients. Where I come from, the needs of the patients come first. And I'm glad to say that joining the compact is safe for patients. By joining the licensure compact, patients can count on the highest quality care. The standards of nurse licensure compact ensure that nurses are highly trained and they have passed the FBI background check. And finally, members, joining the compact is good for Minnesota. The licensure simplification is proven and tested, folks, in 39 other states. 39 other states. Once again, Minnesota remains in the small minority of 11 who have not yet adopted this patient-friendly, good for Minnesota, good for nurses program. It would also be invaluable during the pandemic, as we saw. And we saw that non-compact state nurses had to wait to get their licenses to be approved, or they had to have the licensure requirements waived temporarily through emergency orders. We must note that there were no issues with that. In fact, it was very helpful during the pandemic. And now, members, today you have the opportunity to make sure that these hurdles do not remain in place, and that it would allow Minnesota to join the compact. It would provide a durable increase in the workforce immediately. It would be good for patients. It would be good for nurses. It is a real way to improve health care, to make sure that we solve and get more nurses at the bedside. Members, I encourage a green vote for this amendment, which will actually get more nurses at the bedside. And I do call for a roll call, Mr. President.
Roll call, requested roll call granted. Senator Wiklund to the A101 amendment.
Thank you, Mr. President. And I would urge members to vote no on this amendment. This is a complex it's a complex amendment that's brought to you. It's 19 pages long. And if we want to have a discussion about the merits or the concerns, this should be something that goes through the relevant committees so that adequate discussion can be had about it. As I see paging through it, there's rulemaking, there is references to current labor laws in the state. This needs to be heard in the relevant committees so members have a chance to understand the full impact on Minnesotans, and I oppose the amendment. I am also not in agreement that necessarily all the benefits of this as were presented would be seen in Minnesota, but we absolutely need to have a full hearing in the relevant committees in the Senate.
Senator Murphy.
Thank you, Mr. President. And thank you, Senator Nelson. I feel like we are reprising an act from 2 years ago. I am also rising in opposition to Senator Nelson's amendment to include the nurse licensure compact. And I pulled, in preparation for this debate today, some of the licensure statistics, most recent in the last year, from the Minnesota Board of Nursing. We often hear about the compact as a solution to the shortage, and we often hear the shortage expressed as positions opened in our hospitals. But we see a steady uptick in the number of active licenses here in the state of Minnesota. In 2018, it was 109,251 active licenses. That has steadily increased, and in this year, there are 130,246 active licenses for registered nurses here in the state of Minnesota. In April and May of 2022, the board issued 3,475 permits for RN endorsement applicants. Nurses are coming here to practice. Nurses are coming here. There are lots of licensed nurses here in the state of Minnesota. The shortage of nurses, as it is expressed, is a nationwide shortage. So trying to draw nurses from other places through the compact as a solution to that problem, when the numbers show that that is not our problem. The problem is not nurses coming here. The problem is not nurses getting licensed here. The problem is there are nurses who have licenses who are not willing to practice in our hospitals right now, and that's what we're trying to fix. The compact, while a solution that has been taken up by many states, has kind of come to its end in terms of the number of states that are no longer willing to engage, and there are nurses and states that are now exploring whether they can pull out. I think the compact is reaching its natural end. I think there are better ways for us to think about interstate practice. I like the model that medicine has taken up much better than the nursing model. I would pursue that. But this is a solution that will not solve the shortage of nursing in our hospitals, and I would ask people to vote against it. Thank you.
Members, before we go to the author of the amendment, any additional discussion? Senator Uckey.
Thank you, Mr. President. I just got to thank Senator Nelson for doing this. Last year, we had a lot of discussions around the nurse licensure compact. There are many, many positive and worthwhile parts of that. We hear about the number of nurses in our state. Yes, that's true, but we have a need for a lot more. And we need to make it easy for the nurses to move around. We know that today's society is mobile. I have heard about many young people that have gotten their nursing degree. They don't stop in Minnesota to get their nursing license. They go to one of the other 45 states and get their license because they are mobile. They are going to move around. They like to see the country. They work in one area for a number of years and then move on to another, and they don't want to have to go back and start over with their license. Of course, they all have to maintain their license. They have to keep it up with continuing education and training. So there's nothing different about it. There's no reason for us not to do this. Even if we only gained one more nurse, it'd be worthwhile. But the potential to gain a lot more is great, and we're educating a lot of these young nurses, and yet we're exporting them to other states to find work. So let's keep them here. Let's support this amendment. Thank you. Vote green.
Senator Grudenhagen.
Oh, thank you, Mr. President. Yeah, I rise in support of the A101 Senator Nelson amendment. Members, I just encourage you to do a little bit of study with Milton Friedman. God rest his soul. Milton was a Nobel Prize-winning economist. Most of Asia adopted his economic philosophies, and they prospered. And one of the cornerstones of his philosophy is the free flow of labor and capital in a capitalistic system. That's what creates prosperity. Now, will it solve all our shortages? Probably not, but it will take a step in the right direction. Instead, what government does, it builds fences around a state or even a nation, and as they build fences of regulations and laws, they actually inhibit their own prosperity. So members, One other statement from Milton Friedman was, if you put the federal government, and we could say state, in charge of the Sahara Desert, in 5 years you have a shortage of sand, okay? So that's government. They need to be a referee, not get into the huddle and make the calls. Please vote green.
The last voice we'll hear before the vote will be that of the amendment author, Senator Nelson.
Thank you, Mr. President. I appreciate the discussion today, and I just want to add a couple things before you prepare to cast your vote. Some important pieces you need to know, members. Yes, this bill did pass off our Senate floor in the past. I want you to know that the Minnesota Board of Nursing supports the Nurse Licensure Compact for the reasons that I have already stated. I also want you to know that there are many, many other organizations who support the Nurse Licensure Compact. In fact, you'll recall it was a full page of supporters. I'll just name some of them. Health Partners Hospitals and Clinics, the American Red Cross, Mayo Clinic, Gillette Health Systems, Essentia Health Systems, Sanford Health, Health East, Minnesota Organization of Leaders in Nursing, American Association of Nursing Administrators, Care Providers of Minnesota, Aging Services of Minnesota, American Association of Ambulatory Care Nurses, Minnesota Hospital Association, and various other health-related groups. And you might recall from those hearings, members, that the military came out in force to support this as well. If you think about how their members travel across the states. So this is critically important. Now, for full disclosure, I also want to tell you who opposed this bill. There was one group, and it was the Minnesota Nurses Association was opposed to this legislation, and as I noted, their membership is about 10% of all registered nurses. I encourage members that you do what is best for patients, support our nurses. Let's get nurses at the bedside. Please support this with your green vote. Thank you.
The Secretary will take the roll on the A101 amendment. Members, please vote. Senator Bowden, for those voting under Rule 40.7.
Thank you, Mr. President. Senator Dietzick votes no.
Senator Dietzick votes no.
And Senator Gustafson votes no.
Senator Gustafson votes no. Senator Jasinski, those voting under Rule 40.7.
Thank you, Mr. President. Senator Lang votes aye.
Senator Lang votes aye. Members, please vote. All senators having voted who desires to vote, the Secretary will close the roll. There being 32 ayes and 35 nays or noes, the A101 amendment is not adopted. Senator Uckey?
Thank you, Mr. President. At this time, I'd like to offer the A68 amendment.
Senator Uckey offers the A68 amendment. The Secretary will report the amendment.
Senator Utke moves to amend Senate File Number 2995 as follows. Pages 133 to 146, delete sections 8 to 17. This is the A68 amendment.
Senator Uckey, to your A68 amendment.
Thank you, Mr. President. Members, this amendment simply deletes the mandated nurse staffing provisions from Article 3 of this bill. The sections that are affected are 8 through 17 and 19 through 25, and those all affect the staffing ratios. I want to be clear, the language keeps the loan forgiveness program for registered nurses, and it keeps the violence prevention sections of this bill. Everything else in that article remains intact. It's just staffing. And I want to make 4 distinct and important points why this language is why the language I removed is not necessary, why it could cause more harm than good, and why it doesn't address our real challenges of workforce shortages. Number 1, quality of care. One of the most respected quality organizations is the federal government's AHRQ, the Agency for Healthcare Research and Quality. They do comparisons of all 50 states with a state benchmark dashboard. Most recent data shows that Minnesota has achieved a benchmark on 92 measures, while California has achieved a benchmark on 67. California is the state which has had mandated nurse staffing ratios for over 20 years. Of course, there are many factors that go into creating quality of health care, but it doesn't assume that this bill will improve our quality of care. Of course, a hospital has to have adequate staffing, not just registered nurses, but the entire care team. In order to deliver quality care, our Minnesota hospitals have that. It is already publicly reported every quarter how many nurses there are on every single hospital unit and how many patients were on that unit. This has been in law since 2014. Minnesota hospitals are transparent in their staffing and are providing quality care. Number 2 is access to care. Proponents of this legislation have readily said that patients should be turned away. Rather than expecting a nurse to care for an additional patient, that is above the established number of allowable patients as determined either by this new committee or through this new mandated, legally binding arbitration process. This is wrong and bad for our communities. While the bill avoids using the word ratio, setting a maximum number of patients that a registered nurse can care for is a ratio, regardless of whether the specific word is used or not. Hospitals won't be allowed to admit additional patients if it is above the ratio limit. Patients will back up in the emergency rooms even more than what is happening now. Hospitals will likely discontinue providing some services, and there will be less access to care. And then we have the increased cost. This bill will dramatically increase health care costs. Hospitals will be paying for all their employees to serve on the various staffing and workload committees. And in the meantime, those shifts will need to be covered by other hospital care professionals. Massachusetts, a state slightly larger than Minnesota, has a health policy think tank similar to the Affordability Board being proposed in this bill. In Massachusetts, it was estimated that implementation of the staffing ratio bill would cost our healthcare system a minimum of $639 million annually. Final point is workforce. According to DEED, Minnesota currently has 52,000 healthcare vacancies, 5,000 of which are registered nurse positions. Hospitals have 3,800 RN positions they are trying to fill. These vacancies are not because Minnesota hospitals are bad employers. This is a situation that is occurring around the country. It is estimated that Minnesota will need between 43,000 and 50,000 more nurses by 2030. That is just 7 years away. For the first time, we have openings in our nursing schools, and with available spots for more students, we have a demographic problem of more retirees and fewer workers. Nurses will not be coming back to the bedside because they will get to participate in a committee meeting, or because hospitals will have to post their staffing plans on the units of the hospitals. What will help is getting more nurses into the workforce and addressing violence in the healthcare setting. The staffing section of this bill are not ready in their current form to pass into law. And for that reason, members, I would ask that you support this amendment to withdraw those sections. Thank you.
Senator Friends.
Thank you, Mr. President. On behalf of me and Senator Jasinski, I just want to say we are glad to do the work of roll call and requesting roll call votes and reporting remote voters. And with that, Mr. President, I request a roll call vote.
Roll call requested, roll call granted. Senator Wiklund to the A68 amendment.
Thank you, Mr. President. I would oppose the amendment, and I ask members to vote no. The Keeping Nurses at the Bedside Act, the integral part of that bill is the staffing section, and we need to retain that within the bill. We know that there is a sense of urgency about addressing nurses' concerns about their workplace and their working environment. And this portion of the bill seeks to do that work to address that. The bill's chief author has worked on the bill, moved it through the committees in the Senate, and we have made changes to address concerns. And we need to keep these sections within the bill to continue to have discussions and to continue to work to address patient safety and also nurse safety, basically their mental and physical health, and find ways to retain them in their hospital workplaces. Members, I urge you to vote no.
Senator Murphy.
Thank you, Mr. President and members. I will also respectfully ask for a no vote on this amendment and ask for your support to retain Keeping Nurses at the Bedside Act in this important legislation today. I want to thank Senator Wiklund for including this provision and to thank my colleagues both sides of the aisle for their support and their input and their efforts to improve the bill. And Senator Wiklund is right. We have made many amendments to this proposal in this session, and I would expect that could happen again as we proceed. But I am very, very proud of this work and incredibly proud of my nurse colleagues across the state who have brought to us a proposal for our strong consideration. The first time this legislation to address staffing in our hospitals was introduced, it did include a strict ratio in the legislation. That is not in this proposal. Instead, the nurses are asking to do the thing that I think we all believe in, is to put them at a table with the executives, the hospital administrators, the nursing administrators, to make a decision together about how to staff the facility in that community. We, elected officials, are elected by people to sit at a table together and wrestle with the things that challenge us and draw a conclusion. Sometimes I've heard people say, well, I don't know why we would want nurses on committees. They should be taking care of patients. I think that's kind of a funny response given what we do for a living. We resolve problems by talking together, and the nurses want a seat at the table, so much so that they're not demanding a majority seat. They're demanding a minority seat. And yet they believe and have faith that when they talk with the people in that hospital, that they will reach a conclusion together about how to adequately staff nursing and patient care. I want to tell you one story from my practice, and it's been a tick since I have practiced nursing, but I was a night nurse in a hospital in rural Wisconsin. There were just 2 registered nurses on a 50-bed unit, and we had nursing assistants and other staff, all important, a part of the team. I had a long hallway of patients. There was a new patient just discharged from the intensive care unit who had been newly extubated, and he was afraid that he couldn't breathe. His issues were anxiety that night, and I couldn't really care for him. All I could do was run by his room and say, I hope you're doing okay, keep breathing. Another patient I had coded that night. The first time that had ever happened to me. I was a new nurse. He had a heart attack. I was the one in the room. I called the code. I started CPR and did CPR until the code team arrived, and then assisted that code team until that patient met his end. He died that night. A third patient in my care that night had a GI bleed in their hospital bed, bleeding. You know, we called for help, but it took a number of hours in the middle of the night to get a surgeon to come in to take care of that patient and get that patient discharged. That was a rare event, but if you listen to nurses now, they will tell you that is their standard practice. And that night, if we had gotten admission to the unit and we were a med-surg unit, so we were the normal place that people admitted patients to. If we'd had gotten admission that night, that patient would not have gotten quality care, would not have gotten the admission that they deserved, would not have gotten the assessment they needed. And that's what the nurses are saying to us. Give them the tools to make sure they can practice nursing with the skill and the dignity and the professionalism and the excellence that we want for Minnesotans across the state. For a decade, they have been working for this. They have made so many changes. And now what they're asking is to be at the table, to bring their voices to that. That's not a hard thing. And Senator Utke, when you talk about violence in the workplace, you know what the solution to that is? Adequate staffing is the solution to that. And yes, people working in hospitals, doctors, nurses, nursing assistants, and others are getting hurt. We should address that. But for our loved ones, for the Minnesotans who are going to get care in our hospitals, this is a critical issue. There are nurses who are licensed in Minnesota who are not coming to work in our hospitals. But it's not because there aren't enough nurses. It's because of the moral injury. And if you listen to nurses, they're crystal clear about that. So now is our time to act, and I'm going to ask you respectfully to vote down Senator Utke's amendment and vote for the nurses and for patient care in our hospitals. We can get this done together. Thank you.
Members, I'm just going to gently remind us to stay on the amendments. We are on the A68 amendment. We're going to Senator Gruenhagen.
Well, thank you, Mr. President. Yeah, and thank you, Senator Murphy, for being a nurse. You know, about 20-some years ago, I was hospitalized for about 10 days, Methodist Hospital. And I used to refer to my doctor and the nurses as angels, okay? Because they truly were in terms of the care I received. You're doing God's work, okay? But I do have to rise in support of Senator Utke's amendment. You know, one of the things I learned as chief negotiator when I was on the school board was that you do not negotiate away managerial rights. And that's what we're doing here. We're having a top-down nursing ratio, and God bless the nurses for taking care of the people that they do, but the state's coming in and saying your ratio to patients will be X, okay? Here's what's the results gonna be. You or your loved ones one day are gonna go to the emergency room and they're gonna turn you away, not because they don't have an open bed, members, but because they have a ratio that they legally have to follow. That's what's going to happen, okay? So think long and carefully before you vote down this amendment that we are giving away and mandating from the state one size fits all. And again, God bless those nurses. I received great care when I was in the hospital, and it greatly aided to my recovery. But members, you're going the wrong direction. Like so much of this bill, it's going to create higher cost and less access for our citizens. Please, members, support Senator Utke's amendment. We don't want you turned away in your hour of need as far as health care. Thank you. Vote green, please.
Senator Abler.
Thank you, Mr. President, and I cannot count how many times we've discussed this topic and the challenges that face nurses and the patients who truly want to benefit from their care. But, Mr. President, this is a compromise. This is this is the answer. This is time now to get this to pass. The problems that remain are massive. If you're on the patient side or on the nurse side. My mom just is getting out of the hospital, and so she was down in Florida and received pretty good care, and I wasn't there, and so we were worried about how that was going to work out, and so the little local hospital took good care of her. She's just coming home today. And so what I hope for, what I presume is when my mom or somebody goes to the hospital, that there are going to be people there at the entry place, and they're going to have sanitation, and they're going to have, like, you know, the right things in the right bottles, and there's people who know how to put them to do whatever those have to be done with. And that when it comes to the hour-by-hour care, that when you push the button, or if there's something that needs to be done at a timely time, that there'll be a human being in the form of a nurse or their other crew to do that thing. And we assume upon that, and we talk about the cost of healthcare. We pay a lot of money to the hospital for the privilege of getting served in that way. Mr. President, I hate to tell you, it doesn't always work out that way. In fact, there are nurses who I know who have talked to me, and they said, I can handle for these 4 patients that I have. They're really complicated, but I can do these 4 because I've got the talent and the skill and the training to do this. They come to me and they say, well, good, now you have to do 2 more, and they're just as complicated. And the nurse says, what am I supposed to do? And so what can she? She can't walk out the door. So now they have, or he, and they have 6 now people, and the light goes off, and nobody can go there. This is what's going on now. And then they go to their charge nurse and to the management, and they go like, well, hey, I felt incapable to do the care. This bill addresses that. This bill creates committees to discuss what on earth is the capacity of these nurses to do their job. And very often, though, the response is like, oh, just go back to work. Like, and they suffer very great professional challenges and dissonance in their heart about what is the right thing to do. And they're also, Mr. President, they're bound by the Board of Nursing to abide by an ethical standard and to do what they believe is right. What do they do? Beyond that, Mr. President, they go to work having had the challenges of their home, and now they're going to go and take care of all the things I just mentioned. But in too many cases, the patient chokes them or elbows them or makes some kind of an assault on them, and they go home. They're already frustrated from maybe overload, but now they're injured. And so they didn't go to work to get injured. They went to work to be a professional nurse, to deal with the ills of mankind, and instead they go home injured. Nurses shouldn't go to work to get injured. Nobody should go to work to get injured. Injuries happen from time to time, but they shouldn't be like a regular thing. And I'm really shocked in the negotiations that this wasn't resolved. And in the committee, we heard from some hospitals around the state, small towns, like we have a committee, we get this worked out, everybody's happy. I said to the bigger groups, why don't you listen to them and make the committees work that way? Mr. President, this bill is about committees. The language suggests they be removes committees. It removes the inside the hospital local control that can be done in a collaborative way. I don't know any nurses who can't wait just to get even with their employer and like really show them up. They want to serve the patients. They want to be healthy. Mr. President, this piece should stay in the bill, and I urge members to vote red. Thank you.
Members, I want to make sure that the last person that we hear is going to be Senator Uckey. Anyone besides Senator Pratt? Senator Pratt, and then Senator Uckey, and then we will vote.
Thank you, Mr. President. Would Senator Wiklund yield for a question?
Senator Wiklund, will you yield? She will yield. Senator Pratt.
Thank you, Mr. President. Senator Wiklund, I understand there are about 19 local hospitals owned by local government units. And I'm wondering, have you come to any sort of agreement with them on what the local impact might be by implementing these provisions?
Senator Wiklund, to the question.
Thank you, Mr. President. I know that there have been discussions and there have been modifications to address some of the concerns of rural hospitals. I don't know if that would apply to all of the hospitals that you are mentioning, Senator Pratt, but I can't say I'm not the one that has been in as many of the negotiations and the discussions as one of the author of the bill, and she could probably confirm or provide more details on those.
Senator Pratt.
Thank you, Mr. President. Would Senator Murphy yield for a question?
Senator Murphy will yield. Senator Pratt.
Thank you, Mr. President. Senator Murphy, we've got these 19 hospitals which tend to be rural or urban. Do you have any idea what the impact to these community-owned hospitals will be?
Senator Murphy, to the question.
Thank you, Mr. President, and thank you, Senator Pratt. I believe the impact would be a positive impact for the hospitals and for the community members getting their care in those local hospitals. That's one of the reasons why this legislation is so important. There has been some negotiation among the parties to make sure that there's not a one-size-fits-all when it comes to hospitals, including our rural hospitals. But to your question, I believe the impact will be a positive one.
Senator Pratt.
I'm sorry, Mr. President, I didn't get that last part of the answer.
I think she said that she's sure that it's going to be a positive impact. Is that what you said? That's what she said. Senator Pratt.
Thank you, Mr. President. Would Senator Marty yield for a question?
Senator
Marty.
Marty. Senator Marty, will you yield? He will yield. Senator Pratt.
Thank you. Senator Marty, serving together on the Finance Committee, you and I have talked on several occasions about the impact of new mandates on local governments. Can you tell me, have you requested a local impact note on this portion of the bill?
Senator Marty, to the question.
Mr. President, Senator Pratt, no, we have not, and I think I don't know that this is going to be a big financial impact on local governments. I don't know that it's going to have any impact on them.
Senator Pratt.
Well, thank you, Mr. President. Mr. President, we have 19 locally owned nonprofit hospitals. They would be some of our rural hospitals. They would be some of our most frequently used hospitals like HCMC. When a similar bill went through Massachusetts, they estimated the cost on the entire system to be $639 million. I asked those 19 hospitals what they thought what impact this might have on them. They told me they felt just for those 19 hospitals, we might be looking at $30 to $50 million in new unfunded mandates. Now, to Senator Abler's comments, there are parts of this bill that we can certainly get behind. No one should go to work and feel like, and not know that they can go home uninjured, that they can be safe in their workplace. But some of the administrative requirements, the administrative mandates in these sections will have a real financial impact to our rural and urban hospitals. And I'm disappointed to hear, Mr. President, that we haven't requested that local fiscal note, that local impact note, that we haven't gone out and tried to figure out how much of a burden we're going to be putting onto these locally owned hospitals and these local governments to continue to provide the quality of care that Minnesotans so desperately need. So, Mr. President, I ask members, just based on these questions, to vote in favor of the Uckey Amendment.
The last voice that we'll hear before we vote will be that of Senator Uckey, the author of the A68 Amendment. Senator Uckey.
Thank you, Mr. President, and thank you, Senator Pratt, for highlighting the financial part of this. I have talked to some of those hospitals also, and they are extremely concerned. The nature of being a medical provider in these small hospitals in the past has been they provide great services, but they've been able to just barely hang on, but yet they've always had positive numbers. They've shown a little profit at the end of the year, pay their bills. Now they're telling me, and I had one that's been profitable for a lot of years, and he told me yesterday, this year we're not. This whole thing is sliding, and the language that we're removing will help them to make sure that they don't go over that fiscal cliff sooner than they envisioned, but they are afraid. I've heard about adequate staffing. Numbers on paper don't equal adequate staffing. We are all different in this chamber, nurses are all different, and the patients they serve are all different. You can't just put a number on the clipboard and say, this is it, we live by it, because in some cases that number is too high, and in other cases it's too low and we can be flexible. We need to leave that flexibility in the current management system. Nurses are involved in those decisions. They have lead personnel that work with the administration, and that needs to stay in place. Whether it's a hospital, a school, or an auto shop, they all have an organizational chart. School teachers don't set what the superintendent does as far as the curriculum and everything they have to do. The auto mechanics don't tell the general manager what to do, but as a team they get the job done, and they all have to work together or the place is not going to be successful. That's what takes place in a hospital, and that's why we're saying we need to remove the language that I have removed in this amendment so that that teamwork continues and we don't basically turn this thing upside down. As it's set up, it's not workable. The costs are going to increase greatly, and it's going to put a lot of our small providers, all the way up to our big providers, in a very tough fiscal position, and that we definitely don't want. Because in the end, when we do all need health care, we want to be able to show up and have wonderful people service. Nurses do a tremendous job. We appreciate everything they do, but we just have to make sure that they're going to be available when we hopefully need them. So thank you, Mr. President, and I ask everyone to vote green.
The Secretary will take the roll on the A68 amendment. Senator Bowden, for those voting under Rule 40.7.
Mr. President, Senator Dietzick votes no.
Senator Dietzick votes no.
And Senator Gustafson votes no.
And Senator Gustafson votes no. Senator Jasinski, for those voting under Rule 40.7.
Thank you, Mr. President. Senator Lang votes aye.
Senator Lang votes aye. Members, please vote. All senators having voted who desires to vote, the Secretary will close the roll. There being 30 ayes and 35 noes, the A68 amendment is not adopted. Senator Liskey.
Thank you, Mr. President. Mr. President, before I introduce my amendment, I would like to ask if Senator Murphy will yield for a question.
Senator Murphy, will you yield? Senator Murphy will yield, Senator Liskey.
Thank you, Mr. President. Mr. President, my question is, does Senator Murphy know what the CMS Rule 482.23A is?
Senator Murphy, to the question.
Senator Champion, Mr. President, Senator Liskey, without looking it up, I would not be willing to say yes or no.
Senator Liskey.
Thank you, Mr. President. Mr. President, luckily I have it here so we can talk about it. The hospital, it reads this: standard organization. The hospital must have a well-organized service with a plan of administrative authority and delineation of responsibilities for patient care. The director of the nursing service must be a licensed registered nurse. He or she is responsible for the operation of the service, including determining the types and numbers of nursing personnel and staff necessary to provide nursing care for all areas of the hospital. So my interpretation of that is that it is down to one nurse must make the decisions and not a committee. So with that, I would like to move the A71 amendment.
Senator Liskey moves the A71 amendment. The Secretary will report the amendment.
Senator Liskey moves to amend Senate File Number 2995 as follows. Page 138, line 25, delete projected number of. This is the A71 amendment.
Senator Liskey, to your A71 amendment.
Thank you, Mr. President. Mr. President, this amendment is strictly to remove the language around the ratio, the undefined ratio, actually, in this bill. It does not take anything else out from the nurses at the bedside portion of this bill. All it does is remove the undefined ratio and takes away the ability for the committee to assign specific staff to specific locations.
Senator Westland.
Thank you, Mr. President. I request a roll call.
Roll call requested, roll call granted. Senator Wiklund.
Thank you, Mr. President. I would urge members to vote no on this amendment. This would weaken the language around how the staffing committees are established, and I need to go back and look more at what is being deleted, but I believe that it will weaken the area of the bill that has to do with setting up staffing committees, and I would oppose the amendment.
Any additional comments before we let Senator Liskey have the last comment? Senator Murphy.
Thank you, Mr. President. Just very briefly, in the bill, the work that we have done to amend the bill has addressed this issue that Senator Liskey is bringing up, making sure that the chief nursing officer is able to continue to do their work under that federal regulation. But the part that I think is most important is every registered nurse is licensed under the Board of Nursing, under state law, and is responsible for the professional conduct of that license. So it is not just that one nurse who is responsible, but every registered nurse who's taking care of patients in the hospital who is responsible.
Any other comments before we go to the Senate author of the A71 amendment? Seeing none, Senator Liskey, before we vote.
Thank you, Mr. President. Mr. President, I appreciate Senator Murphy's response. It's good to know that we are taking care of at least the federal regulations that are involved here. Again, my concern here with ratios, whether they're defined or undefined, is that we are setting ourselves up for failure if said one of our parents, one of our grandparents walks into the hospital with an emergency. The ratio is set, it's defined, it's strict. They are no longer allowed to accept that patient. They now must go to a different hospital. And in my community, where, first of all, I have to drive 20 minutes just to get to the nearest hospital, I will suddenly now have a 45-minute drive to the nearest hospital after that. It is my concern that rural hospitals will suffer from this, and so will rural patients. And so that is why I have offered this amendment. So I please urge members to vote green.
The Secretary will take the roll on the A71 amendment. Senator Bowden, for those voting under Rule 40.7.
Thank you, Mr. President. I report that Senator Dietzig votes no.
Senator Dietzig votes no.
And Senator Gustafson votes no.
Senator Gustafson votes no. Senator Jasinski, for those voting under Rule 40.7.
Thank you, Mr. President. Senator Lang votes aye.
Senator Lang votes aye. Members, please vote. All senators having voted who desires to vote, the Secretary will close the roll. There being 31 ayes and 34 noes, the A71 amendment is not adopted. Any additional amendments? Senator Coleman.
Thank you, Mr. President. I'd like to offer the A76.
Senator Coleman offers the A76 amendment. The Secretary will report your A76 amendment.
Senator Coleman moves to amend Senate File Number 2995 as follows. Page 65, line 29, after the period, insert. This is the A76 amendment.
Senator Coleman to your A76 amendment.
Thank you, Mr. President. I would like to start by thanking Senator Wiklund for her attention and care to infertility in this bill. The amendment has to do with that portion of the bill. We know that getting pregnant isn't always easy. Someone who is diagnosed with PCOS, I know that that can put a lot of fear in the hearts of people trying to start families. As many as 1 in 8 couples suffer from infertility, and there are so many tough decisions that they have to make along the way. I have friends who have been diagnosed with cancer and have had to make these tough decisions for themselves, and one of the things that filled their heart with dread was what was going to happen to their unused embryos or the ones that were not viable. Deciding what to do with leftover embryos or embryos deemed non-compatible with life during IVF should not be one of the tough decisions that families have to make. This amendment requires that IVF patients be notified that instead of destroying unused embryos, there is an option to have them buried at no cost to them or the clinic. Giving patients the option to bury their unused embryos at no cost to them or the clinic gives them the peace of mind that every life created in the process was treated with dignity should they so choose to have that happen. And I would ask for a green vote. Thank you.
Senator Westland.
Mr. President, I ask for a roll call.
Roll call requested, roll call granted. Senator Wiklund.
Thank you, Mr. President. Yes, and thank you, Senator Coleman. I would like to understand the amendment better, but I do think this is a very specific and complicated area, and I would urge members to vote no. I think it needs to have a lot more discussion with people who are very involved in the in this topic, and I would not be comfortable adding it to the bill at this time. Thank you.
Any additional discussion before we go back to Senator Coleman? Senator Abler?
Yeah, thank you, Mr. President. And, you know, Senator Wiklund, well, thanks, Senator Coleman, for bringing this forward. I think this is just one of the more personal things a person can ever go through is trying to have this experience and talk to a number of families who have had this, and it's really hard. And you walk into it suddenly needing this particular service you didn't even know you were going to be visiting about this, and like, so here we are, and there's just nothing more close to home than this situation where you're so excited and so challenged and hoping that, you know, that is this the one that's going to work, and now we've missed, this is the two have failed, and now we have a third one, and you know, please God, would you help this be our child? And so, and I don't think people always understand that there's some extras there, and they may know, but and so those extras are actually fully fertilized embryos that are 5 or 6 days old, and they're alive, and so I talked to one person, and they weren't allowed to take their extras, their little future potential children with them, and another person didn't know it was even something to ask about. And so, you know, Senator Coleman, thank you for bringing this up. I think it's pretty cool. And Senator Wiklund, you know, this doesn't do any harm to your bill at all. I think if it's at least could be a placeholder for allowing people to complete the process in a way that would be respectful of something they didn't even know that they should be thinking about. And I'm really happy to work with you, Senator Wiklund, if you would just consider taking this as just something that we can agree on here, that people in the middle of this and working their way through finding success could have the way to close the process up. And so I'm not going to ask you to yield, Senator Wiklund. I'm not going to do anything. I'm sorry there's a roll call on this thing. This is not a roll call kind of a bill. This is could we just decide that we're going to care about the humanity of each of us and the humanity of these little embryos, and like we did yesterday, a lot of humanity was yesterday, caring about seniors and people with disabilities. And so I'm not even looking at you, Senator Wiklund. I'm just going to sit down and then you get to decide, and you know, I'm not in charge. But I would just think it'd be a great statement that we could agree on this little thing, that people can complete the process and have the privilege of going home and having the proper treatment of these little embryos in their own home or somewhere, or not. They don't have to do anything. And there's like no money and no complexity to it, really. Thank you, Mr. President.
Any additional discussion before I go to the author of the A76 amendment? Senator Aaron McQuaid.
Thank you, Mr. President. This actually was my bill, and I'm so excited for its inclusion today. We had folks from Resolve here. It is Fertility Day at the legislature. They were sitting in orange. I think we have some folks up there now still. And so this is just near and dear to my heart. Every person who wants to be a parent should be able to be a parent, and that's why I advocated for this part's inclusion in the bill. What I will say, as somebody who's gone through fertility treatments, is that there are very specific procedures that clinics use when it comes to embryo collection, storage, and disposition. And so this amendment would possibly create something that might not be in existence at clinics. It might interfere with something that might already exist at clinics. And so I'm going to ask folks to vote no, because I don't think we've really thought through the ramifications of what this could disrupt if we don't thoroughly vet this. So I'm going to ask folks to vote no, and I think this is something we can work on in the interim to find out how we can meet the needs of everyone who's going and using IVF. Thank you.
Senator Coleman.
Thank you, Mr. President. Members, I would urge a green vote. I would have to respectfully push back that this complicates any process whatsoever. Some men might turn green in the room right now, but when I gave birth to my twins, they said, hey, you want to bring your placenta home? I said, no, thank you. But if it's that simple to bring home something that you created or that is in a hospital setting, it should be simple to give these parents the right to bring home what they think is a piece of them or their child to properly bury as they deem fit. It just simply says they have a right to do so and that they should be notified of that right. Please vote green.
The Secretary will take the roll. Senator Bowden, for those voting under Rule 40.7.
Thank you, Mr. President. I report that Senator Dietzig votes no,
Senator Dietzig votes no.
and Senator Gustafson votes no.
Senator Gustafson votes no. Senator Jasinski, for those voting under Rule 40.7.
Thank you, Mr. President. Senator Lang votes aye.
Senator Lang votes aye. Please vote. All those having voted who desires to vote, the Secretary will close the roll. There have been 32 ayes and 34 noes. The A76 amendment is not adopted. Any additional amendments? Senator Nelson.
Oh, thank you, Mr. President. I have the A102.
Senator Nelson offers the A02 amendment. The Secretary... A102 amendment. The Secretary will report the A02 amendment.
Senator Nelson moves to amend Senate File number 2995 as follows. Page 70 after line 17, insert. This is the A102 amendment.
Senator Nelson, to your A02 amendment. What did I keep saying? 02? The A102. Let me just say that. Senator Nelson.
Thank you, Mr. President. I am glad to stand and offer the A102 amendment. Members, we are talking about across this chamber, across the state, how do we reduce the cost of health care? High quality health care, access, and reducing the cost. Some people say it's impossible to do all three of those things, but I do not believe that's the case. Before us, we have one way that we can reduce the cost to consumers, and this is called point of sale rebates. And as you know, pharmacy benefit managers, particularly, there's 3 of them that control 80% of pharmacy benefit managers. They control not the cost of the drug, but what they do is they give rebates to the insurance company so that those certain drugs that actually might be more expensive drugs, but that those more expensive drugs will be on the formulary. And that is the rebates coming from pharma go to the prescription drug benefit, PBMs. And what they do is they keep that money. Yet, what happens to consumers, just like you and me and our constituents, all across their state. Those plans do not share the discount with the patients. Now, the health plans do share the negotiated discounts for doctors and hospital visits with patients, but they do not share those lower discounted drug prices with patients. No, they keep them for themselves. And what we should be doing, as other states are doing, which is requiring that those drug rebates, those things keeping the drugs of a lesser cost, that those drug rebates go to the patients. The prescription drug rebates should lower the prescription drug costs for the patients. But instead, currently in Minnesota, we require patients to pay the full price for the prescription drugs at the pharmacy counter when their insurance company is actually getting rebates that make those drugs less expensive. I find that more than a sleight of hand. I find that incredibly disturbing. And I hope you are looking at the sheet that was passed out recently on your desk. It's called Insight News. And I cannot help but think this headline describes what's going on here in the Minnesota Senate as we debate our health bill. State lawmakers are missing the opportunity to fix Minnesota's glaring health problem. And this is by Lawrence Wright. He's a member of the DFL African American Caucus and a Asane Foundation board member. He resides in Minneapolis. And he rightly points out what we've often said, and we've said right here today. We have excellent, fantastic health care in our state. And we know that we're trying to fix some of the problems. But what we're doing is not the cure, members. And as you know, we have the greatest health care in this state, we also have the greatest disparities in health care in this state. And to close this gap, he says, communities of color in our state need access to high-quality health care and affordable prescription medications to combat chronic illnesses like heart disease and diabetes. And we currently are preventing that. But with voting for the A102 amendment, we can make a dent in those high-cost prescription drugs by making sure that the rebates actually go to the patients who are paying for those drugs. It would force PBMs and insurers to share the savings that they negotiate with consumers. It would prevent them from using their formularies to restrict access to affordable generics and biosimilars. Members, if we're serious about reducing healthcare disparities, if we're serious about helping people afford their often life-saving but high-cost prescription drugs, we need to vote for this amendment. Already, to date, 19 states have introduced legislation just this year that would require health plans and PBMs to share prescription drug prices at the point of sale. And I think you're all following along, but just in case you're not, I'm going to give you one quick example of the math on this, because I know we've had a long day. So let's just talk about Gary. He has a $100 list, a non-discounted price. That's how much the drug is. His rebate to the manufacturer is pocketed by the insurance company for $40. And yet that means Gary pays $100, even though his insurance company bought that drug for $60. Now, if Gary lived in a state that shared the rebates, that required that the rebates were shared at the pharmacy counter, Gary would get the $100 drug. It's a non-discounted price. The drug manufacturers had a $40 rebate, just like in the previous example, But Gary then would pay $60. He would pay the actual price of that drug. That's what it looks like when the rebates go to patients, go to the people who are purchasing, who need the drugs. If we're serious about holding down the high cost of prescription drugs, making it easier for Minnesotans to afford them, this is what we should do today, members. I encourage a green vote.
Roll call requested, roll call granted. Senator Wiklund to the A102 amendment.
Thank you, Mr. President. I see this as certainly is an issue that patients are facing, and we do want to see a way to address. Patients on the surface, they see that there is cost sharing going on, and they would like to be benefiting from that. But I think that this is too complex an issue to discuss and resolve and take on the floor as an amendment. I also see it has enforcement language that requires penalties, civil penalties and suspension of licenses, and I think it needs a fuller discussion in a committee about all the ramifications of implementing this amendment. Thank you.
Any other discussions? Senator Mann.
Thank you, Mr. President. You sound so surprised. I am very happy that this topic has been brought up. In 2020, we passed the nation's strongest PBM law, licensing PBMs. And I didn't have as much GOP support when I passed that as I was hoping for. But I'm glad we're all appear to be on the same page today. However, this amendment talks about decreasing cost sharing, but then the very next section talks about confidentiality and how we have to keep all this rebate information a secret, which is the problem in the first place. We don't get to see what those rebates are from the manufacturer to the PBM or to the carrier, and when that is a secret, no one knows what's happening, and this amendment changes none of that, unfortunately. And there's no language in here about formularies and not being able to use the formularies to kick people off their medications. So again, it doesn't do really anything. So I would urge a no vote on this particular amendment, but I would love to keep the conversation going about what we can do to decrease the profit margins of PBMs and keep people on their medications.
Any further discussion on the A102 amendment? If none, the last voice that we're going to hear is the author, if she chooses to, Senator Nelson, and then we will vote.
Well, thank you, Mr. President. This is a good amendment that will help. It does not address everything. However, the PBMs are rightly defined as the issue, and I did support the PBM legislation of previous years, and we need to do so again. I mean, I'll just give you a few more. No, I won't even give you any more comments. I've made the case. This is to get rebates at the point of sale, right there at the pharmacy counter. They go to the person paying for them, and it is what we need to do if we want to diminish the role of those negotiated prices through the PBMs, and if we want to make sure that Minnesotans, that we're holding down the high cost of prescription drugs. It also has the benefit of making sure that generics and biosimilars also receive equitable or fair treatment, and that the rebates go to the patient, the person, the consumer who is paying for them.
The Secretary will give the A102 amendment, will take the roll. Members, please vote. Senator Bowden, those voting under Rule 40.7.
Thank you, Mr. President. I report that Senator Dietzig votes no,
Senator Dietzig votes no.
and Senator Gustafson votes no.
Senator Gustafson votes no. Senator Jasinski, for those voting under Rule 40.7.
Thank you, Mr. President. Senator Lang votes aye.
Senator Lang votes aye. Members, please vote. All senators having voted who desires to vote, the secretary will close the roll. There being 31 ayes and 35 noes, the A102 amendment is not adopted. Any further amendments? Senator Gruenhagen.
Oh, thank you, Mr. President. Yeah, I'd like to offer the A65 amendment.
Senator Gruenhagen offers the A55 amendment. 65 amendment. The secretary will report the A65 amendment.
Senator Gruenhagen moves to amend Senate File Number 2995 as follows. Page 542, delete Section 1. This is the A65 amendment.
Senator Gruenhagen, to your A65 amendment.
Oh, thank you, Mr. President. Yeah, what this does, members, it deletes the creation of the Healthcare Affordability Board. I've renamed it the Healthcare Unaffordability Board with less healthcare access. And what it does, members, we just got done talking about the cost of bureaucracy on our healthcare system. Again, nationally, it's over $1.3 trillion to micromanage what doctors you see, when you see them, and how much care you get. Members, the last thing we need as Minnesotans is a politically appointed board determining what health care they deserve according to when they need care. Instead of allocating funds to set up and administer this bureaucratic board, we should be addressing the needs of mental health resources in our schools. And members, this again moves, it deletes that board and again moves about $1.4 million in 2024 to mental health grants for our schools, and then about a little over $1.7 million in 2025. So members, this is the crisis, the mental health crisis we have in our schools. We don't need this board. And members, can't you just see this board? What they're going to do, they're going to try to keep costs down, and that's going to result in rationing and to micromanage the doctor-patient relationship, which we already have enough bureaucrats doing that. Members, I'll give you an illustration on what this does, okay? Now, if you have a boiling pot of water, all right, and the burners turn up to high, what this board does is put a cover on the boiling pot of water. Is that going to solve the problem? It doesn't turn the burner down. All it does is build up pressure in the pot until it explodes. So members, again, this is another board that takes us down the road of less access and higher costs. And the last thing we need to do is increase bureaucracy here in the state of Minnesota over our healthcare system. Members, please vote green.
Senator Westland.
Mr. President, I ask for a roll call.
Roll call requested, roll call granted. Senator Wiklund.
Thank you, Mr. President. Again, the school-linked, the mental health grants are a worthy item, but I also think that we need to be looking towards the future. We need to be finding ways to analyze and assess the impact of healthcare costs on our state. The duties of this board, it would be to monitor and look at payment systems. It would be to look at enhancing the transparency of provider organizations. It would be to monitor the adoption and effectiveness of alternative payment methodologies and foster innovative healthcare delivery and payment models that lower healthcare cost growth while improving the quality of patient care. All of these things are activities that we are not spending enough time on today, and I believe that this Healthcare Affordability Board, with members chosen by not only the governor but also the legislature, would have specific knowledge in the areas of healthcare finance, health economics, healthcare management, and at a senior level, healthcare consumer advocacy, the healthcare workforce, and many other criteria that could be used to select members. So members, this is something that we need to leave in the bill and use to make sure that our state is moving forward in a more effective way in analyzing and assessing responses to rising healthcare costs. So I urge members to vote no.
Senator Abler.
Thank you, Mr. President. And I hate to keep saying I've been around here for a while, but I have. I haven't forgotten some of the things we've done, like some people have been around here a long time. Just as time goes on, you kind of forget half the good stuff you worked on. Mr. President, there has been a great deal of effort put into healthcare affordability, healthcare access, healthcare improvement, healthcare exploration. Governor Plenty did it. Governor Carlson and him made up the Minnesota Care deal way back when, I think. And just no end of efforts and no end of studies, no end of work done. And at the end, we wound up with what we have, and which is literally the most expensive system in, not just in Minnesota, but as a country. We have the most expensive system in the world with some of the most mediocre outcomes. And there have been no end of ideas about how to improve upon this. Total cost of care, managed care, provider scrutiny, higher copays, lower copays, and it's all commendable. This board is commendable, and maybe it'll work at this time. I don't know. I didn't bring the amendment to touch any of it, but I just want to call attention to some of the features of this that concern me. And the one is that they're going to have some idea about what the increase in cost should be, kind of ill-defined about how that'll be spread out by providers. And they have to submit plans on page 552, which is part of the amendment deleted. They have to file a plan, which starts on line 550.25 and so on. That whole section is about plans and what they're going to do. And so there was, sometimes if you have to pay based upon the acuity of your clients and you're going to get dinged because you're spending too much, you're going to want to get less acute clients. And that's a risk. In New York, they talked about these performance standards for doctors, and the doctors who did the best were the ones who just didn't take the ones that were hard, because they got better quicker, they were cheaper, and like lo and behold, they got a good performance rating. And the doctors who took the ones who were ready to die, who might need the actual little help to live a few more days or you actually get cured with some complex services, threw all their stats off. And what we have now, Mr. President, is a bunch of we're coverage units. You and I, Mr. President, we are coverage units in a state employee program. And when you're United Healthcare or Blue Cross, you want to get people in your plan because you get so much per head for everybody. And some people are really expensive and some other ones are way cheaper. And if you're lucky, you'll be the health plan that gets the healthy ones, you'll make some money. And so the idea that anybody can control costs enough to hit a target means you're going to have to find somebody to not care for. And so frankly, Mr. President, if I'm in this thing, I'm not going to care for the sickest person because, well, actually I would, because then I'd be in trouble again, but I would risk that because it matters and because that's the kind of people we are in this body, because we risk on behalf of our people. But to hit the target that you're going to have to do in this little program, you have to achieve your performance plan. And Mr. President, if you don't, or if you don't even get around to filing it on time because it's really hard, you could be charged $500,000 on line 552.8. And, you know, the board will not do it right off the bat. But there's there's some teeth in this. And so if you're going to pick who you're going to choose, are you going to pick the elderly as part of your cohort that you want to really reach out to a lot? Are you going to want to pick people with disabilities who might have some really severe needs? In Minnesota, we've already got it covered. We let people with disabilities choose the HMOs or fee-for-service because then they get to pick where they want to be. And so it's well-intended, and it's going to move forward, and it's going to be part of the bill, and hopefully in conference a few of the bugs can be worked out of this so it may actually work. And I talked to Senator Wiklund about this, and I understand totally where she's at. And I feel kind of like I hope she does better than the Vikings do in all their Super Bowls. So, yeah, you hope that the quarterback for the 5th Vikings Super Bowl is going to be on their game. And you wish them to succeed. And so, Senator Wiklund, I hope you succeed with this where others have failed. But please, as we go forward, let's just make it so it works. Thank you.
Any additional discussion before we go to the author of the A65 amendment? Seeing none, Senator Gruenhagen.
Oh, thank you, Mr. President. I don't know, did I ask for a roll call or not?
A roll call was requested, and a roll call was already granted.
Okay. Yeah, I think Senator Abler articulated a lot of what I was going to say yet. And again, members, the illustration to have in your mind, why hasn't all this bureaucracy and all the insurance companies and the HMO in government to micromanage the doctor-patient relationship? We need to free up the doctor to take care of the patient the way they should be. They're the ones on the front lines. They're the ones to make the decision. We don't need more bureaucracy. We've tried the bureaucracy way. It doesn't work. And instead, you're piling more bureaucracy on. Again, this board and other things in this bill, higher cost, less access. And unfortunately, some of the most acutely sick or accidents are the ones who are going to suffer under this, members. So members, please vote green. We don't need any more bureaucracy.
The Secretary will take the roll on the A65 amendment. Members, please vote. Senator Jasinski, for those voting under Rule 40.7.
Thank you, Mr. President. Senator Lang votes aye.
Senator Lang votes aye. Senator Bowden, those voting under Rule 40.7.
Thank you, Mr. President. I report that Senator Dziedzic votes no.
Senator Dziedzic votes no.
And Senator Gustafson votes no.
And Senator Gustafson votes no. Please vote, members. Senator Bowden.
Thank you, Mr. President. I also report that Senator Fate votes no.
Senator Fate votes no. All senators having voted who desires to vote, the Secretary will close the roll. There being 33 ayes and 34 noes, the A65 amendment is not adopted. Any additional amendments. Senator Gruenhagen.
Oh, thank you, Mr. President. Yeah, healthcare is in my wheelhouse, I guess, because I've been selling health insurance since 1978. The next amendment I was going to offer was the A66. However, I'm going to withdraw that and not offer it. It's about another board, another bureaucracy, and higher cost and less access, but we'll leave that one since we saw the way the other one did.
And Senator Gruenhagen, remember that you can always talk about those things on third reading.
Yep. I do have one more amendment, okay? And that is the A64 amendment.
Senator Gruenhagen offers the A64 amendment.
Oh, no.
The Secretary will report the A64 amendment.
I'm sorry, it's not the A6. I got that mixed up. Hold on just a second, Mr. President.
I'm sorry.
It's the A72 amendment.
The A72 amendment. Senator Gruenhagen offers the A72 amendment. The Secretary will report the A72 amendment.
Senator Gruenhagen moves to amend Senate File Number 2995 as follows. Page 96 after line 15, insert. This is the A72 amendment.
Senator Gruenhagen, to your A72 amendment.
Oh, thank you, Mr. President. Yeah, members, now, I've cursed the darkness quite a bit in this bill, but here I have an amendment that actually lights a light, and it's called reference-based reference-based health care, okay? So what does that mean? Well, I belong to a committee of about, 10 to 15 retired and active doctors, retired and active insurance agents, and over these last 10 years, we came up with this reform. It's an option. It doesn't replace anything. It's simply an option in state statute that insurance companies can offer. And what it does, and you heard Senator Marty complain about the bureaucracy, and I've harped on the bureaucracy. So Senator Marty and I both agree that a lot of waste, fraud, and abuse and high cost of our healthcare system is the bureaucracy. And not only does it create high cost and waste, fraud, and abuse, it also micromanages, in many cases, the doctor-patient relationship. We need to free the doctor up, and we need to allow patients to go to the doctor that they desire and want rather than their network. Now, in the last 10 years, one of the things I learned from some of the doctors is that our health insurance companies in this state, or HMOs, they can basically come to a doctor within a day or two, and for whatever reason, they don't even need to give one, they can push that doctor out of the network. Well, those doctors, 50 to 60% of their patients are in network, in some cases more. So they have the risk, if they don't cooperate with these overlords from the HMOs, to lose a huge percentage of their income and patients basically overnight. Currently, according to the information was shared, they don't even have to give them a reason why they kick them out of the network. They can just do it. Members, that's ridiculous. So we basically have these doctors who are locked into listening to bureaucrats and micromanaging them in terms of what, if, and how much health care they can give. And the networks are shrinking, which means there's less choice coming across for our health care system, along with pre-certification and everything else. What reference-based health care does, it eliminates 90% of the bureaucracy. There's no networks. It's for the individual and small group market, and the patient selects a plan to pay so much over Medicare, either 50%, 100%, 170%, or up to 200%. So when they go to the doctor, they can have a plan. They can go to the doctor of their choice, and their plan they can tell the doctor, my plan reimburses 100% over Medicare. And it's subject to the Obamacare rules and open enrollment and everything else. So it still is guaranteed issue. There's no underwriting. But it eliminates over 30% of the bureaucracy, which will drop premiums and deductibles dramatically. The other thing to understand, because it reimburses at a much higher rate than Medicare or Medicaid, it'll help stabilize the hospitals and doctors with higher reimbursement versus going with a government-run bureaucracy and single-payer plan. So members, this is an option. That's all it is. But it frees up patients, and it's only those who want to take advantage of it. So it frees up a patient to go to the doctor of their choice. The doctor is no longer micromanaged by a bureaucracy on what they can and can't do. They don't have to worry about losing their patients. And members, it's a big step in the right direction as far as cost. The other thing is, I'll give one last example. Let's say I have a plan that reimburses 100% over Medicare. So I go to a doctor and he says, I ask him, will you accept 100% over Medicare as far as reimbursement? And he says, no, I want 150%. Well, at that point, you either have to pay the difference or you have to go to a different doctor. But you get to control where and who you go to, not a bureaucracy of networks. So members, and each year during open enrollment, you can select a higher reimbursement or a lower reimbursement plan depending on your relationship with the doctor. The patient replaces the multi-billion-dollar bureaucracy, both in our health insurance companies and in government. So please, members, support this option and vote green. And thank you for your consideration.
Senator Wiklund to the A72 amendment. Senator Wiklund.
Thank you, Mr. President. Well, I think it is an option. I think it is something that, if it were to be implemented, would require a great deal of examination, and that would need to be done certainly in conjunction with the Commerce Committee. And I see some big questions that I would have about how networks or how people who enroll would actually have access to providers. It leaves a lot to be figured out, and so I would ask members to vote no.
Senator Klein.
Mr. President, I request a roll call.
Roll call requested, roll call granted. Any other discussion before we go to the author? Seeing none, Senator Gruenhagen.
Well, thank you, Mr. President. Yeah, thanks for that response, Senator Wiklund, but you don't have a network. You don't have the micromanagement of the bureaucracy. You get to go to the doctor of your choice, and you replace that bureaucracy with patient choice and liberty. It'll be refreshing to the doctors, and it won't have low reimbursement that they'll turn you away. You might have to take out a plan with a little higher reimbursement, but these plans, if offered as an option, would dramatically reduce your deductible, and it would dramatically reduce your premium. Because as Senator Marty said, it's the bureaucracy that is causing the majority of waste, fraud, and abuse and higher costs in our nation and state. And the last thing we need to do is get more bureaucracy. We need to free up the doctor to let him practice medicine rather than fill out forms and report to a bureaucrat that doesn't know as much as he does about the patient. So please vote green for this option. It's a big step in the right direction, addressing the bureaucratic waste, fraud, and abuse. Thank you, members.
The Secretary will take the roll on the A72 amendment. Senator Bowden, for those voting under Rule 40.7.
Thank you, Mr. President. I report that Senator Dietzick votes no.
Senator Dietzick votes no.
Senator Gustafson votes no.
Senator Gustafson votes no.
And Senator Fate votes no.
And Senator Fate votes no. Senator Jasinski. Those voting under Rule 40.7.
Thank you, Mr. President. Senator Lang votes aye.
Senator Lang votes aye. Members, please vote expeditiously, please. All senators having voted who desired to vote, the secretary will close the roll. There being 33 ayes and 34 nays, the A72 amendment is not adopted. Senator Coran.
Thank you, Mr. President. Mr. President, I'd like to move the A100 amendment.
Senator Coran offers the A100 amendment. The secretary will report the A100 amendment.
Senator Coran moves to amend Senate File Number 2995 as follows. Page 86, after line 3, insert. This is the A100 amendment.
Senator Coran to your A100 amendment.
Thank you, Mr. President. What this amendment is around the contract evaluation for the Prescription Drug Price Transparency Act. There are states all over the country that brought up transparency acts or transparency websites in hopes of expanding information and knowledge to consumers. Minnesota's website didn't turn out so well. The website was greatly delayed and only finally showed some of the required data in February 21st of 2023. The original law was passed in 2020. The fiscal note for this particular project was slated to be around $140,000. And for that, we'd get a basic website, data collection, public database with warehousing with public and non-public data, and an external website which permits users to search on a wide variety of parameters. Today, that particular contract, 10 to 11 Business Solutions, had contracts for the very same information. It's totaled about $900,000. Each contract is for information technology development for the Prescription Drug Price Transparency Project and Program. Minnesota Department of Minnesota Department of Health is behind schedule. There was a report required and due in the legislation for May 15th of 2022. Department of Health failed to meet this requirement. It was never produced. There was a report due on January 15th of 2023 from the Department of Health. That report was also not completed. Then you get into the new year. The first information was available February 21st, 2023. It's the first time information was available and showed any drug price transparency data, and over the first 13 months from the implementation is when it showed the first manufacturer reporting detail. What this does is the transparency site lacks some basic functionality. It's not very useful. In Senate File 2995, it adds numerous and significant drug pricing reporting and requirements. And so with that, Mr. President, I think it's prudent on us to make sure and look in that this amendment really just requires the agencies to review the entire procurement process from their procurement and ensure that we actually, before we invest any more money, that this contract is going to live up to its expectations, and that's what it does, Mr. President. So I request a roll call and encourage a green vote. Thank you.
Roll call requested, roll call granted. Senator Klein?
Mr. President, I raise a point of order under Rule 7.4 that this creates a increased cost to the omnibus bill in front of us. Subdivision 1 does not allow that, and I ask you to rule this amendment out of order.
Advice? brief advice so I can talk to the fiscal people.
Thank you, Mr.
Senator
President.
Rasmussen.
Thank you, Mr. President. Yeah, advice on this. I think you should find the point of order not well taken. If you look at the A100 amendment, there is no appropriation, there's no change in net revenue, and again, if you look at Rule 7.4, it says that there must be a change in net appropriation, change in net revenue. This amendment does not do that. It simply says that the Commissioner of Health must evaluate contracts. Evaluation is things that the Commissioner of Health and the Department of Health do on a regular basis, and this is something that they ought to be able to do as a part of their course of business.
Senator Coran.
Mr. President, advice and follow up Senator Rasmussen. This would only require then define a review of the program that would not add additional costs. Part of the routine activities within a particular agency for all procurements, with the additional information that's required from the agency in this bill, it wouldn't increase it. It's just a normal course of their activities in a daily. Just calls out the particular program in which should be evaluated, and would urge you to roll out of order.
Vice, Mr. President.
Senator Klein.
Mr. President, I withdraw the point of order.
He has withdrawn the point of order. Any additional discussion on the A100? Seeing none, the Secretary will take the roll on the A100 amendment. Members, please vote. Senator Bowden, those voting under Rule 40.7.
Thank you, Mr. President. I report that Senator Dietzig votes no.
Senator Dietzig votes no.
Senator Gustafson votes no.
Senator Gustafson votes no.
And Senator Fate votes no.
And Senator Fate votes no. Senator Jasinski, those voting under Rule 40.7.
Thank you, Mr. President. Senator Lang votes aye.
Senator Lang votes aye. Members, please vote. All senators having voted who desires to vote, the Secretary will close the roll. There have been 33 ayes and 34 noes. The A100 amendment is not adopted. Any further amendments? The Secretary will give the bill its third reading.
Senate File Number 2995, a bill for an act relating to state government, modifying provisions governing child care, child safety, and permanency.
Third reading. Members, I'm going to take the list for those who are going to speak on third reading, and we know at the end the last two will be the ranking member and then the chief author. Okay, hold on a second. Who else? Abler's already on the list. Who else is on the list? Okay. Okay, Mitchell. Members, I'm going to go over the list one last time, and this will be the list. Port, Murphy, Marty. Oh, no, you're not on the list. Is that right? Okay, he's not on the list. If he's shrugging his shoulders, it means no. Abler, are you on the list? Abler? No, thank you. Gruenhagen. Oh, you are on the list? Okay. Gruenhagen, Senator McQuaid, Mitchell, and then it would be Uckey, and then Wiklund. Did I miss anyone? Because I don't want anyone to say that I was moving too quickly. That would be the list. Senator Port.
Thank you, Mr. President. Members, over the last 3 years, my life has changed really dramatically. I've had kidney failure, irregular heartbeats, chronic fatigue, constant nerve pain, balance and dizziness issues. These are now daily realities for me. As I've struggled to find care, and then to have that care be covered. I've had dozens of conversations with other patients and advocates and doctors. The investment in this bill to address access to long COVID care and resources is absolutely critical, and I want to thank Senator Wiklund for including it in her bill. 10 to 15% of Minnesota adults have some long COVID symptoms, with 83% of those reporting activity limitations. Over 56,000 Minnesotans are currently reporting severe limitations on daily activities. Around 17 million job-age Americans are estimated to have long COVID, and 3 to 4 million working Americans are out of work due to long COVID. There are economic impacts, physical and mental health impacts, family burdens, financial hardships, quality of life concerns, human impacts. This is a critical issue that is facing our economies, our communities, our families, our friends. And I'm really, really glad, Mr. President and Senator Wiklund, that we are including this provision in the bill. It's critically needed. Thank you.
Senator Murphy.
Thank you, Mr. President and members. Thank you, Senator Wiklund, and to the committee members for bringing together such a powerful proposal for Minnesota. I ran for office for the very first time after caring for my mom, and she had to fight to get the care she needed, despite having really, really good health care insurance. We made a decision in this country nearly 100 years ago, nearly 100 years ago, that our health care coverage should come through our employer. I think that was a mistake, but that's me. But one of the things I really love about this proposal is thinking through the opportunities that we have for people who have no access to coverage or whose coverage is too expensive to get access to Minnesota care. And in particular, that we are considering that for people who aren't documented means the world to me. I think healthcare is a human right. I think people who show up to get care in a clinic or a hospital should get care. That is my responsibility as a nurse. I believe that should be our responsibility as a people. And I see this proposal taking us one step further in that direction, and I'm really grateful for that, and I'm proudly going to vote yes for this proposal today. Thank you.
Senator Abler.
That was quick. I'm going to ask Senator Marty to yield in a minute, just so he can be prepared for that, and then we'll see if he will yield. So, Mr. President, this bill is another in a long line of efforts to make a difference in Minnesota's health and human services niche. And I want to thank Senator Wiklund for the way she's run her committee. We didn't always agree. Well, we agreed on many things. Let's go with that. But she was always very polite to listen to my concerns. And we mostly had enough time. Some of the days we just ran out, and that was a discussion we had some months ago. And her staff was nothing short of exceptional, and the council has been amazing, and the pages and all that. It was a really good crew, and I think the collegiality was very good. So I wanted to thank her for that, for leading that tone. The product that we have here, I just lost my notes, is something that always gets discussed about what we can do. I'm just curious if we can actually afford some of the items that are in the bill, and I wonder if Senator Marty would yield to discuss that.
Senator Marty will yield. He will yield. Senator Abler.
Thanks. Here, found my glasses, Mr. President. Senator Marty, looking at the fiscal note, which I know you scrutinized this thoroughly, and I talked to fiscal staff about this, and I have yet to get an answer about it. I mentioned this to you in the hallway as well a few weeks ago. This bill draws from some funds beside the general fund. And so there's a general fund target, and then there's other funds brought in. I'll give you an example. In the TANF fund, it spends enough money that would deplete it in 2031. So that's kind of good. At least based upon the money in the bill, it's going to last a while, and I appreciate seeing that. There's like 20-some thousand out of TANF, so that's good. The Healthcare Access Fund, on the other hand, I'm really concerned about that. Senator Marty, Mr. President, Senator Marty, the bill spends a total of $927 million in 26 and 27, and also $411 million in 24 and 25, which depletes the fund down to $276 million. As I read what's purchased in here, it appears that these are buying things that have ongoing costs. And I may have to have Senator Wiklund yield to the other question of this, but Senator Marty, that's a net, assuming, well, just $927 million is added on to the general fund spending in the second biennium. And it appears to me these are ongoing costs with like rates and including people, the very thing Senator Marty or Murphy was excited about, the undocumented people are going to get coverage paid for out of this fund. So Senator Marty, can you explain to me what in 2028 the Healthcare Access Fund will look like, and also the impact on the general fund in 2028 of this Healthcare Access Fund infusion being treated as though it's spendable money?
Senator Marty, to those questions.
Mr. President, Senator Abler, it's a legitimate question to ask how we're going to keep the balance of these funds in healthy shape. I think Senator Wiklund's committee did a reasonable job of trying to do this. I do know there's more money coming out of the Healthcare Access Fund in the next biennium. I think that there's some reasonable decisions that were made here. I think that the bill will be fine. I think that they are leaving close to $300 million in the fund at the end of the last biennium. But yes, it's a legitimate concern. We're looking at, we're perhaps the only state that looks 4 years out in our budget cycles, as you know, and I think that's valuable, and I think we do a pretty good job with it here. Have concerns, want to make sure we do this well.
Senator Abler.
Thank you, Mr. President. And I appreciate Senator Marty's effort at an answer to that. Unfortunately, it's not an answer, and I didn't come here to beat him up on this. I really want to know the answer. The targets in this bill were achieved based upon the general fund spending, and there was like in the range of $1.5 billion or $1.7 billion or something like that. If I recall, I don't have those right handy in my own head here, but in terms of additional funds coming into the budget, there was $32 million in the second biennium coming out of the state special revenue fund, $51 million out of the TANF fund, and $927 million out of the Healthcare Access Fund, which is money spent in addition to the general fund, which is going to have, in my understanding, additional spending needs. We have to keep spending this money in 2028. And that is more than $1 billion in that biennium. So maybe Senator Wiklund can help me with this, Mr. President, if she would be willing to yield. Senator Wiklund, Mr. President.
Senator Wiklund, will you yield? She will yield. Senator Abler.
Well, thanks. And we kind of discussed this briefly in the committee and didn't know what the bill was going to look like, and so we didn't answer all those questions. But Senator Wiklund, you probably heard my question for Senator Marty. So if you read on line 14 of the spreadsheet, the last number in that line is $927 million in expenditures out of the Healthcare Access Fund. And if you read line 31, you'll read that there's $276 million left in the Healthcare Access Fund, which was part of the global agreement. And so my question, and so sometimes we take items out of the Healthcare Access Fund and we put them in statute that they're going to be forever brought out of the Healthcare Access Fund. So Senator Wiklund, can you tell me how much of that $927 million is allocated as new statutory spending out of the Healthcare Access Fund, and which is simply a one-time use of that money?
Senator Wiklund, to the question.
Mr. President, Senator, there is another healthcare access fund document that was provided to the Finance Committee, which I have here, which I can provide to you, which might answer your question, rather than me trying to read numbers off of here that get at your question.
All right, yeah, I have not seen that, and so maybe I can.
Senator Abler.
Maybe, Mr. President, I can look at that and then just resume my questions later. And I don't want to burn the committee the floor with this time, but I just want to make the point. I believe that probably there's some spending that's going to be going forward which is not accounted for. Will be a general fund burden in 2028, and we might be surprised. So, thank you.
Senator Grudenhagen.
Well, thank you, Mr. President. Yeah, I know the people who worked on this, including Senator Wiklund, they meant well, okay? But, you know, if you put a lid on a boiling pot of water and you're hoping that solves the problem without turning the burner down, it doesn't solve the problem, okay? So, members, if there's one thing I want to leave you with, we've gone down the road of more government in our healthcare system, more bureaucracy, and less competition. We've gone down that road. And here we sit with a bureaucratic mess overseeing one of the best healthcare systems in the nation. And going further down that road, which is what this bill does, is not going to make things better. It's only going to make things worse. Just a couple examples. That nursing ratio station. Members, we had long-term care discussion not that long ago here in the Senate floor. What was one of the statistics that we heard? Over 11,000 seniors were turned away from our nursing homes from entry when they were certified to go in. Why did that happen? Even though the nursing homes had empty beds. Because of a ratio of care with the staff. So you know what's going to happen when we implement this ratio? You're going to have a severe, and it's already almost there. You know, a couple years ago, my wife fell and and broke her elbow, which is an extremely painful accident. And we went to the Glencoe Hospital, and they couldn't treat it, obviously. They took an x-ray. So they called around to see where we could find a bed that would accept Emily. And I just thought, honest to Pete, she's in so much pain, and they might not find a bed. Well, they finally did late that next morning, like 3 o'clock in the morning. And it happened to be at Regents right here close to the Capitol. So we're already right there, members, in terms of our access. If you implement this ratio, you're going to have the same type of statistics you've got in the nursing homes. You're going to have patients being turned away for their health care rather than having the access that we all want them to have. And members, I want everyone, regardless of income or where they're stratified in society, to have access to the best health care they can at the time that they need it. This bill takes us further down the road of more bureaucracy, more government, more micromanagement of the doctor-patient relationship. We need to free the doctor up. And this bill doesn't do it. To give the treatment and care that he believes the patient needs. He doesn't have to constantly submit to a bureaucrat, government or insurance, for approval, with the threat of being kicked out of the network if he doesn't do what they say. So members, we tried that approach. Please, for the sake of your children and grandchildren, okay, and those are the citizens of the state of Minnesota, let's go in a different direction. We can do that, even under the current federal and state rules. But we can't do it if we keep believing that more bureaucracy, more government is the solution to our healthcare problem. It's only going to make things worse, and in the end, in order to control costs, they're going to ration healthcare. based on your height, your weight, your age, and your health condition. That's where we're going with this. That's what we've seen in other countries with single payer, and even here in the United States that it's failed. Please vote no on this bill, and let's do reforms that actually increase access and lower cost. Thank you, Mr. President and members.
Senator McQuaid.
Thank you, Mr. President. I think sometimes when we have big bills, particularly big bills that are feeling technical, the enormity, the impact, the infusion can pass us by. And so I just want to speak a little bit to how incredibly meaningful this bill is to Minnesotans. There is a CCAP maximum rate increase. That means that now families can afford 3 out of 4 child care providers within their area. That is incredibly meaningful for parents who have children and are looking to afford child care, which I can tell you from personal experience is very expensive. We have child care retention payments. My daughter lost her favorite child care provider to lens crafters. And the more we can do to support child care providers to get paid the living wage for the very highly skilled work that they do, educating and caring for our youngest Minnesotans is amazing. I also want to talk a little bit about the historic investments in equity we see in this bill. We know that Black and Indigenous and people of color in Minnesota have worse health outcomes than white Minnesotans. And this bill seeks to address those both at root cause and also in providers. We invest in the infrastructure for ethnic and minority mental health providers. We invest in more health care for more people. We invest in the African American Babies Coalition. I mean, this bill is going to be life-changing for so many Minnesotans. And so I just wanted to thank Senator Wiklund for her work and for the entire committee's work, because I know so many of our bills go through this committee, but I just could not let this moment pass by without talking about how incredibly meaningful this bill is going to be for Minnesotans, and I'm so excited to vote green. Thank you.
Senator Mitchell.
Thank you, Mr. President. I want to echo some of the sentiments of Senator McQuaid. Thank you so much, Senator Wiklund and staff, for this amazing bill. I, too, as I believe the only single parent of young children in the Senate, have struggled with childcare even during the Senate session. And that really impacts the ability of working moms, especially single moms, to engage in our economy. So I'm really excited about that. I would also like to say thank you for the inclusion as a foster parent of 2 foster care bills that I presented that will ensure more advocacy and more focus on the best outcomes for the children and less about the agency of those children in care, and better outcomes, hopefully, when they come out of care and age out and go into the real world, having a little bit more of a safety net. So there's some really wonderful things in here, and I would hope everyone would vote green. Thank you.
Senator Nelson.
Thank you, Mr. President. This is a big bill. I do want to commend Senator Wiklund. It's a complicated bill. I've served on a number of health committees with Senator Wiklund for a number of years, and I know she comes at this very thoughtfully. And there's a number of things to like in this bill before us, a number of things that I would like to vote for. I'll just list a few of them. The historic investments in young children, our youngest learners, safe harbor, lead reduction, all of these things are important. The child care supports that have already been mentioned. I'm glad to see the school-linked mental health is continuing and being funded at greater amounts. Certainly we know that need has increased greatly. I also appreciate the first episode centers. I started that a couple years ago. I'm glad to see that we're getting more of those across our state. And of course, the residential psychiatric care that can be necessary for young children, and that is growing. And of course, a support for our substance use disorders. But in spite of these good things that I support, I will not be able to vote for this bill today. And I cannot support this bill because of a few large items that I think are incredibly problematic and have long-term negative effects on our state. One of those is the nurse staffing ratio. I'm afraid that that nurse staffing ratio could, number one, keep patients from getting into the hospital that is needed. And we've seen significant shortages of nurses, but I do not believe that the staffing ratio is the way to get to that. That is something that is bargained between nurses' unions and their employers. But to think that a committee is suddenly going to determine nurse staffing ratios, I think, is dangerous. Ratios do not take into account the acuity of patients. It does not take into account the skill of the individual nurses. So I think that is an incredibly dangerous thing, and I cannot support that. There's a second piece in here that I cannot support as well, and that's the Minnesota Care option. As we know, as currently Minnesota Care, it plays lower reimbursement rates to providers. And that will be incredibly hard in our rural parts of the state if those reimbursement rates continue to be cut. So I do not believe that the Minnesota Care option is in the best interest of Minnesota, nor my constituents, particularly in the rural areas. It will be more costly. It will be less reimbursement to providers, and it will, as happened in other states that wanted to move to an option, a public option, they realized, I believe it was West Virginia, that they couldn't do that because the governor was just unwilling to spend. They'd have to double their budget, double the annual budget of the state to move into a fully government-run health care. We cannot do that, members. And then there's the single-payer study, which I think has problems as well because of that government-run health care. And lastly, to add insult to injury, when we have a $17+ billion budget surplus to rob the health care access fund. Now, you know, members, I want to make sure the public knows, the Health Care Access Fund is funded by taxing every health care procedure item in this state, making health care more expensive. And yet we are robbing that health care access fund. So while I appreciate the many good things in the bill, because of these 4 major clunkers that I think will be harmful to Minnesotans, to our health and our health care, I just cannot support it.
Senator Dibble.
Thank you, Mr. President. Mr. President, I just want to rise to thank Senator Wiklund for this bill and for her incredibly hard work, as well as all the committee members and all the staff who have worked so hard in putting together this very, very comprehensive bill that contains a lot of really, really good elements to it. One thing that hasn't been mentioned yet that I wanted to call members' attention to and thank Senator Wiklund for including is an initiative to focus some attention and some resources on long COVID in Minnesota and those who have experienced and struggled with long COVID. This bill would would direct the Commissioner of Health in the state of Minnesota to establish a program to do a number of things, including community assessments, monitor and address the impacts, and bring those communities together in partnership to really focus conversation, inform health professionals, promote evidence-based practices, and research and track related conditions. People have been suffering, many in silence with long COVID, many more people than we realize, and it's very complicated and a very difficult syndrome to understand. So focusing this attention, giving people help, helping healthcare providers and the like as well is very important. Quickly to another subject, as Senator Wiklund talked about the number of elements of her bill, including some attention and focus and resource on the scourge of homelessness, including serving homeless youth. And I thank Senator Wiklund for the increases to the Homeless Youth Act, as well as to those who are struggling with being sexually trafficked and sexually exploited, providing help for those young people who are unaccompanied, who are disconnected, who've been kicked out of their families. Very, very important that we support those young people. We've been stagnant at a little over $5 million per year, despite the fact that these young people represent almost half of the homeless people in Minnesota. 4,500 youth per night, 13,000 young people per year have the experience, the very traumatic experience of homelessness, much of which, of course, is resultant from adverse childhood experiences and a lot of dysfunctionality in their home community and family. These resources really connect young people to what they need, connecting them to community, connecting them to loving and supportive adults, and giving them shelter and food and mental health services, et cetera. However, I will just say parenthetically and for the record, just simply doubling the amount is insufficient. And I know that Senator Wiklund is committed to seeing what we can do as we move on in the process, maybe coming a little bit more close to what the campaign to end youth homelessness in Minnesota is looking at and asking for, and getting us on the path to fully funding the Homeless Youth Act. And I'm confident that that will happen. And then finally, Mr. President, members might be unaware that we have a policy and we have the ability, we have it within our grasp to end HIV in Minnesota. We can do that today if we have the resources and the will to connect people to what they need in terms of health care, in connecting them to HIV medication, helping prevent infections in the first place, housing, mental health services, all those things that represent barriers to care. And the federal government has cut HIV prevention and HIV services. So it's up to our state to make up some of those cuts, and Senator Wiklund's bill gets us on the path to starting to do that. We need to do that in a little bit greater number and on an ongoing basis, as well as more meaningful connection to access to HIV medication, as well as prevention medications if they're on medical assistance. So I look forward to Senator Wiklund's continued leadership as we move towards conference committee, and I look forward to supporting her fine leadership. Thank you, Mr. President.
Senator Rasmussen.
Thank you, Mr. President. And I wanted to just start off by thanking the bipartisan group of members who have been involved with the health insurance mandate review process, both establishing it last biennium and those who have continued to do work on it this biennium, whether it be Senator Frentz, Senator Klein, and Representative Elkins, and others. I think it's important for us, especially as we're looking at health insurance mandates, to understand what cost it will have on premiums and what cost it will have for Minnesotans. Mr. President, as many members might know, we are only able to regulate the fully insured market here in Minnesota, which is largely impacting those who are buying insurance on the individual market as families or individuals, and the small businesses who have to be fully insured. The larger companies that are self-insured, our health insurance mandates don't apply to them. And so if there's additional cost in these mandates, it drives their premiums up. Well, for the larger employers who can self-insure, they're able to keep their costs lower by not having those mandates. And one of the concerns I have with the bill before the body is that from our mandate review process, it's estimated that in year one, there'll be about $124 million in additional cost that will show up in Minnesotans' premiums. And if you go out to year 10, that number goes up to $188 million. And it's important in this bill, for some of these health insurance mandates, we are exempting public plans, such as medical assistance, Minnesota Care, and CGIP. And so even though we started this session with a $19 billion surplus, we're saying that the state of Minnesota can't pay for all of these mandates that are in these bills, but we're going to make Minnesota families and small businesses who buy on the individual market, who buy on the fully insured market, we're going to ask them to bear those costs. And so, Mr. President and members, I'll be voting no on the bill today. I'm concerned about how these mandates are going to continue to drive up already expensive health care costs for Minnesotans.
Senator Parr.
Thank you, Mr. President. I rise in support of this bill. Senator Wiklund did an incredible job addressing the vast and diverse needs of Minnesotans in this bill, making sure that we provide assistance to the people and families who need it most, making sure that we create access to mental health services and health care. We often hear from people, and we often say that we want to create legislation and policies with an equity lens. And I'm so proud to vote for this bill because through Senator Wiklund's leadership, this is legislation that has an equity lens that was created. And I'm just so proud for it. There's many things in this bill that I can bring back to my district and show the people who voted me here, this is what we were able to accomplish for you and your families. So thank you.
We are now going to the ranking member. Senator Abler, before we get to the ranking member.
Thank you, Mr. President. And, you know, the bill is, 600 pages long. The appropriations article is 50 pages, Mr. President, which is longer than some omnibus bills. Sorry for the Commerce Committee on that. But so it's really complicated. This bill is full of great ideas, and some ideas I don't think are quite as great. But it's a decision of the chair, and I know how difficult it is to put this kind of bill together because I've been privileged to do a few of these. But my number one concern in all this, independent of any particular item, is the fact that through the process that we've come to set these targets, this bill is actually going to create a deficit in the general fund. I appreciate Dennis for giving me the information here. That crew, the people that do this work are amazing. The people standing in the back put together all this stuff. Actually, they probably put together more than 1,000 pages of stuff because we didn't do everything. There's some good ideas, Mr. President, that aren't in this bill, if you can believe that they had to write down and you all had to say no to, and I don't know why you said no. But so it's just at a summary level, for not to ruin our viewership, Mr. President, and to make members even in the chamber here just turn glass-eyed. There's a couple main funds that run this budget. The main one is the general fund. The second biggest one is the Healthcare Access Fund. There's a state special revenue fund. There's some TANF money, which comes from the feds for temporary aid to needy families. And there's a child care development block grant and a few other funds that fund this. The major ones in this bill really are the general fund and the Healthcare Access Fund. And so what was explained to me in my little break here was the summary of the Healthcare Access Fund general spending. And actually, I was correct. $927 million in the last biennium came out of the Healthcare Access Fund to supplement this spending. So what does that mean? Well, it means, to break it down further and try to keep it so it's understandable, $633 million came out of the Healthcare Access Fund for 2027. Why is that interesting? Well, because at the end of that time, there's $276 million left in the fund. And assuming that these funds carry forward, and it would be horribly boring, Mr. President, to go through and decide which are carrying forward, I presume most of them are. Because it's the last year of the biennium, and those are the rates, and those are the things we bought that we thought were important. That leaves a structural imbalance in the Healthcare Access Fund of $331 million, which means compared to money coming in and money going out, it's $300 million to the bad, but there's still money in there. But the bill does not call for the Healthcare Access Fund to continue funding those things. There are statutory appropriations in the Healthcare Access Fund that we buy all kinds of things with, which again is beyond the scope of my conversation today. And those are based in the forecast, and then they take those into consideration. The $633 million in the last year of the biennium is not accounted for in the forecast as something that will come out of that fund. And so we have to find a way to pay that $633 million. In there are some marvelous things that people have appreciated. Senator Murphy would like to care for the undocumented, $12 million. But it's not paid for in 2028. It's going to have to come out of another fund, which is the general fund. And last I heard, in the way the targets were set up, there's $125 million in the general fund at the end of 2027, which is a little thin of a margin. That's like 0.2%. Most companies have 5 or 10% of a reserve. And out of that fund came $585 million of medical assistance appropriations. All those rates that people are saying, oh, thank goodness they're raising my rate for this, my rate for that's going to get raised, and worthy increases are not paid for in 2028. And that's my concern just in summary about that. And so what's going to happen when the forecast kicks in next November and later, when they finally get around to looking at 2028 and 29, they're going to be like, holy cow, we're a little short. And that's going to cause some troubles. And so nothing against Senator Wiklund. She followed the rules she was given. But in the rules that we were given, she was given to deal with, which was brought up by your triad of people, is a lack of a consideration for that. And Mr. President, I've been, rather than having to wait on the floor for one of our amazing, Mr. Albrecht bringing me the information, I asked MMB for this information 2 weeks ago. Tell me the status of 28. In the committee out loud, I said, can you tell me where we are then? Tell me the status of the Healthcare Access Fund. And to this point, I've not had the courtesy of a reply, and I don't understand why they can't understand that. When I ask them the question, they go like, oh, that's a good question. Mr. President, you can't spend $3 billion on stuff, including about a quarter of it, which is not supported by future money, and go like, oh, that's a good question. And you should be concerned about that too, Mr. President, because if the general fund goes into deficit, that means that some of the programs you have, the $300 million and change you have in your future monies, are at risk. That means the nursing home funding that we're trying to get yesterday is at risk. That means that every one of these rates here is at risk. And that's my concern. It's not dilatory or unfriendly to the wonderful things in here, but it means that there's more things in this bill that are being purchased to the great celebration of people who are getting to buy them. But then in the fourth year, the bill is going to come due. So that's just a concern. And I just have a few more things, and I do not intend to go very long, Mr. President, and I know you'd like us not to. But a few items I just wanted to point out. There's a bill in here from my good former colleague, Mr. Ellison, Attorney General Ellison, about mergers and acquisitions. And it was brought up in the discussion about Sanford and Fairview and what's going to happen in there. And there's no addressing that in here except for this merger acquisition thing. And Senator Wiklund is well aware of my concerns with this, and she made a few adjustments. But going forward into conference, if this stays the way it is going to chill the effect of many medium, Mr. President, $40 million is a medium kind of business. I want to be in that business, don't you? But that's a medium one, and if there's 40% of that changes hands, it has to go to the Attorney General. And with a look back that can go on interminably forever, which may actually chill people wanting to invest in Minnesota, actually buy some of our failing nursing homes and buy some of support some of the very companies that we hope that they would support. That's on my mind. There's just two fees I wanted to bring up. There's a fee on everybody's phone bill here for 988 suicide, a line, which who can be against that? Mr. President, every other state but 4 fund this with general fund money. And it seems like when you have $17 billion, we shouldn't burden everybody with one more fee on that. And finally, on the fee side, it increases the fees on background studies for everybody, and there's hundreds of thousands of these that are done throughout the long-term care industry, substance abuse, child care, everywhere. They're increased by in the range of 5%. And child care is getting some money, but a lot of these other places are not getting the money to support that. And finally, I talked about this personally with the Commissioner of Health, and I appreciate her being here, and I appreciate the commitment she has toward equity and toward making sure everything works. We put some pressure on them about how the grants were awarded. It was curiously found that at the Department of Health, for all these years they've been awarded, Mr. President, inequitably, if you can imagine that. So they're now going to be improving that, which is ironic because some things are ironic, Mr. President. But there's a whole collage of grants here in the Department of Health that would seek to improve health equity and seek to improve the status of so many different groups that arguably can use the help, and because partly the past they haven't done a very good job of passing out the grants, and some of them just simply haven't worked. But it's a collage. And as I look at this collage, it's an array of nice-sounding projects, and I don't have any amendment to take any out. But I hope as the conference process goes forward that these can be arranged and stuck in parallel with what's already going on and make sure that they actually work. Because if indeed some of the monies that are going to go forward are at risk, you don't want to have money going into programs that are simply not going to produce the outcome that you want. But beyond that, Mr. President, I just want to again commend Senator Wiklund for her running a committee that I was proud to be a part of, and appreciate the discussion. Thank you.
Senator Uckey, the ranking member.
Thank you, Mr. President. And first thing I'd like to do is thank Senator Wiklund for running a good committee. We all got along very well. We had very respectful working relationships around the table. Oh yeah, we didn't agree on a number of things, but there are things in this bill that we will all say that are good, and we've got to continue to talk about those that we have differences of opinion on, and I thank her for that. A couple things, Senator Wiklund, that I'd like to bring up just because we didn't talk about them here today. We've had conversations in the past in the committee, and just to make sure that they're hopefully on your radar as you move forward with this bill. And first item I wanted to start with, in the spreadsheet, we do have a line item for funding for the income verification services available to our counties for the redetermination process. And members, that is the process where over the next year, those on services need to requalify for them. And the numbers in the spreadsheet are $1 million a year. Taking the fiscal note from the other body, because we had talked about this some in committee, and I just want to reiterate the importance of it, and hopefully that we can accept what is coming from the other body. But we've got $1 million a year appropriated. The fiscal note reflects that the cost the first year is $2.345 million. In 24, it's $2.518 million. 26 and 27, that number grows to $2.754 million. What that means is if this bill were to go through as it's currently written, our counties would have to pick up that additional share. So they'd be picking up over 50% of that cost for the income verification services, which is put on them through this redetermination. They now have to have everyone that they deal with reapply and see who is still eligible for services. We know that approximately 400,000 Minnesotans will have to find other means for insurance coverages, et cetera, because they're no longer going to qualify for services after the COVID emergency is over, which it is. But so anyhow, that's one. I hope that we can see new numbers come back from conference committee, and so that we can make our counties whole or keep them whole, so that they're not having to expend extra monies for that. Another item of concern in this bill is the language concerning the merger and acquisition provision, dealing with our health providers, either in a merger or an acquisition. There was a lot of additional languages and restrictions added. Also, parts that empowered the Attorney General, gave him that office a lot of additional authority. That office already represents the state and would take care of all the legal things, but that was enhanced. And I hope that, I know that there's, at least what I'm being told, there's ongoing talks yet on that topic, and I hope that those continue, and I hope that we see some changes there, because at this point, I don't feel that's good for our state and our providers. It's just one more thing that makes it harder for the providers to engage in these things, whether it's a sale, a merger, or whatever they need to do to keep that operation in business. But beyond that, some of these other things have already been talked about. I'll try not to repeat too many things. The Healthcare Access Fund is always a concern. We've seen this year that pop up in a lot of different areas. It seems to be the piggy bank for a lot of excessive spending. And I hope that that gets reeled in. That money is there for a totally different reason. And with the amount of money that was available to have to dip into that is not real good. There are provisions in this bill that we brought up during committee that we had concerns with and thought that they should go to other committees to be weighed in on, debated, and to see where they land. There are still those items in this bill that did not get addressed, and I hope that some of those still can get talked about, because I think they all went beyond the Healthcare Committee. There should be concerns by all of us, and so that we get them taken care of and the language written correctly, so that we don't end up just defending a lot of legal battles outside of this building when it's over. I've already talked some about the cost of this to our local hospitals. This bill is only going to make it worse, and they are concerned, and that's a concern of mine, and I hope that, again, that's something that we can keep in mind as we move forward. Those who were in this chamber back in 2013 and 2014 remember what took place. There was major changes to health care, and in this case that's when MNsure came about, and our health plans and everything changed for our health plans. I happen to live in a part of the state that, due to those skyrocketing insurance premiums, first of all, the major plans didn't even offer a plan in a couple of those counties. They only had some HMOs, and the prices went through the roof. People started to go without insurance coverage at all. We don't forget about those things, and I hope that people don't, because I see some things in this bill that could do some of those same things, and it is concerning. We talked earlier about the cost of the monthly premium going up. So we need to keep an eye on that, and hopefully we can do better. Finally, their studies are proposed to expand the public option and direct us towards single-payer health care. Again, these are studies, but yet we know that what happens if the roadmap is laid out. My question would be, do you want health care dependent on the whims of politicians and regulators? I don't think so. Other states have explored this path, and we have yet to see any successful models. We don't have to jump off the cliff to learn our lesson. Let's look at what others have found and not repeat a bad idea. So with that, members, even though there are some good things in here, there are, for me, way too many things that are still not right. So with that, I will be voting red. Thank you.
We are now moved to the bill chief author, Senator Wiklund.
Well, thank you, Mr. President, and thank you, members, for the discussion this afternoon. I appreciate hearing your thoughts and concerns, and appreciate the things that you say that you like about the bill, and appreciate hearing what your concerns are with other aspects of the bill. Members, this bill, I believe, is a transformational bill. I believe we can see it as one that provides investments in improving the health and strengthening families by providing greater access to health care, child care, and other supports to get children off to a great start. It also empowers communities to be involved in addressing the unique needs of these communities. And I think for us to make progress in addressing the health and racial disparities we see in our state, I believe we need to focus on ways to empower communities to be involved in addressing their unique needs. And I believe it is a transformational bill because it looks ahead. It helps us look ahead to find ways to transform our access to health care. It transforms access to family supports and ways to address rising health care costs. One thing I don't want to forget to do today is to take a brief moment to pause and recognize how far we have come together. Several items in this bill are things we have talked about and worked tirelessly for years. Transformative policies and investments that have been delayed or ignored for far too long. But we finally have the opportunity to move Minnesota forward and pass comprehensive solutions that improve the lives of Minnesotans in real and tangible ways, so that every child has the opportunity to meet their highest potential, and families across the state have the resources and support they need to live healthy and full lives. Because that is what we were sent here to do, and I'm so grateful for everyone who has played a role in getting us to this moment. I look forward also to the discussions ahead, and certainly will take Senator Utke's comments to heart, and we'll be working to address concerns as we move ahead. And I look forward to working hard in the final weeks so we can pass really the strongest budget bill that is beneficial for every Minnesotan, and that we get the bill that every Minnesotan deserves. So thank you, members, and I would ask for your support today. Thank you.
The Secretary will take the roll on final passage of Senate File 2995. Senator Jasinski, for those voting under Rule 40.7.
Thank you, Mr. President. Senator Lang votes no.
Senator Lang votes no. Senator Bowden, for those voting under Rule 40.7.
Thank you, Mr. President. I report that Senator Dietzig votes aye.
Senator Dietzig votes aye.
Senator Gustafson votes aye.
Senator Gustafson votes aye.
And Senator Fateh votes aye.
And Senator Fateh votes aye. Members, please vote. All senators having voted who desires to vote, the Secretary will close the roll. There have been 35 ayes and 32 nays. The bill is passed and its title agreed to. Members, we are remaining under motions. We are remaining under the order of business of motions and resolutions. We'll revert back to the fifth order of business, report of committees. Here at the fifth order of business, Senator Kunesh for a motion to adopt the committee reports.
Mr. President, I move the committee reports printed in the addendum be adopted, and I request a roll call.
Roll call granted. Roll call requested. Roll call granted. Senator Pratt.
Thank you, Mr. President. Pursuant to Rule 21, I object to the committee report on Senate File 2684.
Pursuant to Rule 21, a member may object, and the bill must be referred without debate to the Committee on Rules and Administration to report the proper reference. No action is required. Now we're going to the motion that is before the body, because there's no action required on the Rule 21, because that automatically happens. And did you ask for a roll call vote? Okay. Any discussion? Seeing none, the Secretary will take the roll. Members, you're voting on the motion to adopt the committee reports with the exception of the Rule 21 provided or put forth by Senator Pratt.
Mr. President.
Senator Jasinski, those voting under Rule 40.7.
Senator Lang votes no.
Senator Lang votes no. Senator Bowden, for those voting under Rule 40.7.
Mr. President, I report that Senator Dietzig votes aye.
Senator Dietzig votes aye.
And Senator Gustafson votes aye.
Senator Fateh votes aye.
Gustafson.
Gustafson votes aye.
Thank you.
All members have voted. All senators having voted who desires to vote, the secretary will close the roll. There have been 37 ayes and 25 nays. The motion to adopt the committee report prevails. Members, we will now go to the sixth order of business. Oh, that's right. Members, we're now going to the seventh order of business. That's the second reading of House bills. The secretary will read the House file number.
House File Number 2310.
The House file has been given its second reading. Senator Kunis for a motion to recess.
Mr. President, I move to recess to the call of the President. Members, we will be coming back into session at 6:30 this evening.
And members, just so you recall that today is the state of the state, so that is a part of the process for us to come back and finish our business. Senator Johnson.
Thank you, Mr. President. Senate Republicans, we will be caucusing a regular caucus time at 5:15 over at the MSB. Thank you.
Any additional comments? Seeing none, for the motion to recess, all in favor say aye. All those opposed say no. The motion is adopted. The Senate is now in recess.